early on a Sunday morning. I want to encourage you as much as possible to please move to the front if you can, and to remember to pick a headset at the back. So this is a bilingual session, English and French, and we encourage you, if you are not bilingual, please pick a headset that looks like this, and then you can select the channels which you prefer to listen to. So 1 is English and 2 is French. Okay, so in true African fashion, we're starting a little bit late, and to allow us to also give you a chance to network. So once again, thank you to those in the room. Thanks to our virtual attendees. My name is Agnes Monua, and I'm an Associate Director at Results for Development. I am here representing a group of organizers from ThinkWell, and Namala Ravishankar has been my counterpart there. And then at the World Health Organization is Susan Sparks, who is not able to be here, but is represented very ably by colleagues. So this session has been organized by the 3 organizations, and we extend a very warm welcome to all of you. So the theme of the session is actually very long, exploring the means to achieve universal health coverage in Africa. And we're bringing in insights from a wide panel from Africa, from Asia, and from Latin America, bringing in their lessons and insights that can inform us Africans. And this conversation is very personal to me. I am Kenyan, and in Kenya, if there are other Kenyans in the room can relate, we have a path to universal health coverage through our social health insurance. But we know that our current social health insurer contributes less than 10% to total health expenditure, and that the largest pool of funds is actually the government budget that goes through a devolved system of government. And for us, we have been grappling with how best do we address some of the issues related to expanding insurance coverage. Is that the best means to achieve UHC for our country? What about a large informal sector? Looking at our macroeconomic conditions as a country, and how are we going to get them into a contributory fund? And should we be thinking more of non-contributory options? And so a conversation that's very close. I know we have had many who've said that, and if you've seen a paper that came out earlier this year on being addicted to a bad idea, right? We've read that. And we've also read the rebuttal and realizing that it's not a dichotomy. It's not black or white, contributory versus non-contributory, insurance versus tax financing. And it's really context specific. So what might work for me in Kenya might not necessarily work in Rwanda or in Ethiopia or in Burkina Faso or Cameroon. So what we're hoping to do here is that we're not going to just talk at you. We are going to start with a panel session led by Namala, and I'm going to be handing off to her shortly. And that will take us into our morning. My clicker is not working. So we'll have a first session where we'll have panelists, and Namala is going to introduce them. And then we're going to have a group work session just to hear from all of you. What are your views? What are your insights? And we're hoping to create a safe space where you all feel welcome to share what is going on in your countries, hear your reflections, and what are some of the unanswered questions that would be helpful to inform our research agenda. And we can come out of this session with that. We will all be very pleased. So this session was to run from 8:30 to 12:30. We are expecting that we must leave at 12:30. And so we'll manage time, noting that we started a little late. But again, I hope you do enjoy the session. I hope it's meaningful for you and that you take away something that's useful. So thank you very much. I'm going to hand over to Namala, who's going to take us through the next session. Thank you.
Thank you so much, Agnes. Agnes has been our fearless leader through this whole process and will continue to do so for the day. My name is Nirmala Ravishankar. I'm a senior fellow at ThinkWell, and I'll be chairing this first session of the day, where we'll be doing a couple of things, where we'll be hearing about or we'll be starting with the definitions, these terms that we're using, contributory, non-contributory. what does that mean? How should we think about it? And who better to explain that to us than Joe Cutzon. Joe, of course, needs no introduction, but I will provide one regardless. Until very recently, Joe was leading the health financing team at WHO. And after retirement, he now is, of course, a mentor and a friend and a senior statesman, but he's also a senior fellow at Results for Development. So we'll start with a presentation from Joe to help frame this discussion, go through sort of these key terms. And then we'll be hearing from 4 very capable and informed panelists from different parts of the world. And so we'll be starting with, or well, it's more of a discussion, but we'll have Ibu Beki Prastuti Suwondo from Indonesia. She's a special advisor to the Minister of Health there. We'll also be hearing from Pierre Yamayogo, who is the technical secretary in charge for health financing reforms, as well as the national coordinator for the Gratuité program for under 5 children and women in Burkina Faso. We'll be hearing from Gemini Mte, who works at Apt Associates and is the deputy chief of party for the public sector system strengthening project in Tanzania. And last but not least, we will have Edwin Baraza, who's the director of the Nairobi program of the Kemri Wellcome Trust. And he's based in Kenya. So that's sort of our panel. And so with that introduction, let me hand it over to Joe.
Thanks, Nirmala, and thanks, Agnes, and thanks to all of you for being here early in the morning. I'm going to try to do this from back here, if I can make that work. It's also part of, I was hearing about how senior I was. Part of the way that life has changed, much of the last few years up for everybody, right, has been virtual. I used to not be able to sit still when talking about health financing, and then I had to learn how to do that again. But what I've also now had to learn, now that we're back in this environment, is how to talk while wearing socks, which I haven't done for the last few years also. Okay, so with that, got to always open with a bit of a joke. On this theme of ends and means, or thinking about really the separation of policy objectives from policy instruments, right? That really this is critical to the whole idea of universal health coverage. Universal health coverage is not a way of doing things. It's not something you implement, right? It's a set of objectives that you're trying to make progress on. Equity in the use of services relative to need, or you could say reducing unmet need for quality services while protecting people from financial hardship. And it is an improvement agenda. While it's politically often framed as achieving UHC, even the richest countries in the world are still making choices about what they can and can't pay for from public funding, right? So it's a never-ending journey. That's one part. And the second point, which I'll try to illustrate, is this idea of going from scheme to system, okay? So that the idea of these goals of reducing unmet need and improving protection against financial hardship is not something we're looking at within a scheme. It's about the impact of any reform on those objectives assessed at the level of the whole population. Okay, so that also means we're concerned when there is a particular scheme, not only what happens to its beneficiaries, but what potential spillover effects for the rest of the system. Okay, so given that, the question really should not be reduced to this. Okay, it's not only how do we target and get everybody else to contribute to health insurance, right? Because that's one specific means of doing things. The real question that we want to open that is driven by the objective is how to reduce the barriers to service use, how to improve quality, how to protect, in particular, prioritize poor and otherwise vulnerable. And I think of vulnerable quite concretely now as, I mean, there may be many dimensions of that in a particular country context, but thinking particularly about people with chronic medical need, right? Who are really need to use services and are at risk for high expenditure over time, okay? So how to deal with that, but at the same time, setting and strengthening the foundations for making the system better, more self-reliant, more adaptable over time to take on new challenges. And I think we're going to hear some good examples in the country space. So if you get the wrong question, right? If you basically just reduce everything to the first question, you only have one option and one choice to deal with. So opening the second question really opens up a range of means, a range of potential policy instruments and combinations and how you're going to do things. Just to illustrate this idea that universal health coverage doesn't equal, I mean, universal health coverage is not simply reducible to universal health insurance as commonly understood. I'll go back to some relatively early days when I wasn't so senior, always hearing about South Korea achieving universal coverage in only 12 years because they started their national health insurance in 1977. Everyone was affiliated in 89. But in that year of 1989, when they achieved universal health coverage, 65% of spending was out of pocket. That was after 100% of the population was covered because of the way that coverage was very thin. There were very high co-payments. They were defined as percentages. You know, the longer your hospitalization, the more you had to pay, right? So that existed. And we have many other countries. There's some high income ones here where you don't have contributory health insurance, but more or less everyone has affordable access to services. They still have problems, but it's just to say that you can get there through different ways. And there's lots of in between, I think, as well, as Agnes was saying, you know, there's lots of combinations and so on. So in thinking about policy choices, what I try to do here is categorize them broadly in terms of this idea of the basis for entitlement. And as I've done this in the past, I've heard we haven't always been clear about what that means, contributory and non-contributory, because in all systems, people are contributing in some way. Government gets its money from somewhere. There's some form of taxation. So the critical distinction here is on the basis for entitlement, right? So contributory-based entitlement means that your entitlement to health services depends on a contribution that either you make or that is made explicitly on your behalf, okay? So what we traditionally think of as health insurance is that, but in my view, again, as I say at the bottom, any system can be called insurance. That's just a choice. Non-contributory means that the basis for entitlement is something else. It could be citizenship. It could be residence. It could be being below the poverty line. It could be being under 5 or pregnant woman, you know, all of those things that are non-contributory in nature. And again, what's important is to separate out this technical distinction, which I think for many people here, many of you are, you know, like me, more technicians, from the political choice of how you label your reform, right? And it's important to not let the label limit your thinking and options, okay? But don't take away from this that, oh my God, my country's using the wrong word, okay? That's not really the point, okay? Use the words that work, but don't let those words really put limits on how you think about it. So we've done this idea of thinking about a broad categorization, and there's many combinations, and these are not mutually exclusive. You can have more than one in a given country. But in thinking about contributory-based approaches, I think of two types of things. One is where everybody's kind of on their own. And you may have, again, in a classic social health insurance sense that, you know, people are required to contribute. And often that comes down to people in formal employment without much in the way of government budget subsidy. And then you have some other examples, which is at the lower left, number 2, A2, where you have contributory-based entitlement, but it's heavily subsidized, right? And there are some examples there, Rwanda and China being the low middle income country, but most countries in Europe, Japan, any country with social health insurance that gets to 100% or near 100% affiliation is using general revenues to ensure that those unable or unwilling to contribute are in. And in Japan, it's about a quarter of the revenues of the national health insurance, or that. In other countries, like in Hungary, it's something like 60% are coming from general budget transfers, right? On the right-hand side are non-contributory options. And I'm not going to go into detail, but just to make the point that there are a lot of different approaches. And the bottom two are often more seen in lower income countries. We'll hear some of that. One is that some people can get a range of services. So if you think about what's called PMJ in India, which is basically hospital insurance program for people below the poverty line, right? So it's fully non-contributory, entirely funded from government. It is targeted in the sense that it uses the government and the state government's lists of people below the poverty line. Another example would be the health equity funds in Cambodia, right? Again, non-contributory. If you're below the poverty line, you're entitled to a range of things. Alternatively, in area 4, and think of Burundi, where the president declared maternal and child services and government health centers are free, right? So there's a limited set of services, but everybody in the group is covered. Chile, a higher income country, has something like this as well, where they defined a set of services that are to be guaranteed regardless of which insurance program you're in. So there's a lot of non-contributory choices. I just wanted to also say, since we're in IHEA, we need to say something about economics. And really, I think the issues of concern, which are meaningful in thinking about these choices, is of course the problem of adverse selection when it comes to voluntary participation in insurance. And even if your country says, we'll get around that by declaring everything mandatory, everybody must do it. I mean, taxation is supposed to be mandatory too. It doesn't make it somehow easier to start collecting taxes from self-employed people and people working in the informal economy. So in many cases, what might be called mandatory is de facto voluntary, in fact. And second, that remembering that incentives matter, and simply just adding more budget money into a system won't necessarily improve coverage in terms of improving, improving financial protection and reducing unmet need, unless you really pay attention to how payment mechanisms are working, okay? So just to illustrate that, I often do this comparison of Thailand and China at the start of the 2000s. Both took it as an important policy objective to get to either universal or near 100% affiliation in coverage programs. And they did that by a large increase in government budget spending on health, okay? In China, there was an element of contribution. In Thailand, it was fully non-contributory. So they both increased this. And so if you look at these shares, the public share of total health spending in each country went way up. But what we see on the right side is that this had very different effects. In China, basically, catastrophic expenditure kept going up despite that, despite everybody being affiliated, despite the large increase in public spending. Whereas in Thailand, it was already low, but it went even lower. So what was the difference? The difference was not about injecting more money. It was about how benefits were defined in China with a percentage co-payment or co-insurance, so that effectively the more services you use, the more you had to pay. And critically in China as well, because it was mostly fee-for-service reimbursement. So basically, doctors and hospitals just generated more services. And while public spending went up, private spending didn't go down. It was really good for doctors and hospitals. It wasn't so good for patients, okay? So it's just to illustrate again that those policies matter. It's not just about spending. More generally, there's a set of lessons of what really works, right? So it's this idea of, yes, predominant reliance on public funding. What we call coverage policies are policies on how benefits and co-payments are defined that put explicit limits on out-of-pocket liability. Reducing fragmentation is critical. moving towards more strategic purchasing. You've heard these terms, but concretely, that meaning that that the way payment mechanisms work are driven by data on provider performance, population health needs, and also critically, and again, the Chinese example illustrates this, the US example, to be fair, also illustrates this. The Affordable Care Act, Obamacare, really increased insurance affiliation, but there's no expenditure control, no meaningful expenditure control, and that will undermine ultimately the coverage gains, right? So you need that management of expenditure growth. And the work on PFM, again, given the emphasis on general budget revenues, the importance of giving providers some flexibility over their use and to be able to actually match budgets to service outputs and not simply budget line items, okay? So it's a big challenge. It's always been a big challenge, more so now because of the global context, the economic consequences of COVID, and then Russia's still ongoing invasion in Ukraine has had a big impact, as you know, right? Slower growth, but I think critically for UHC around the world, more inequality and more poverty. So there's changes on the demand side, okay? And as countries responded to COVID, they took on more public debt. So the ability to cope in the future is even more challenging given this. So the challenge is really how to combine the sense of universality and building foundations while also focusing on the poor and otherwise vulnerable, because if nothing is done, these inequalities are growing. And in a way, we might see some movement in the average index of service coverage of financial hardship, but those are not capturing the inequalities, right? Which is really the key issue of our time. So that's broadly kind of theoretical, I guess, in a way, with some practicalities. Agnes said on this contributory, non-contributory, the reality is that countries often have a mix. You already have something. So even if I'm coming down a little bit more on the non-contributory side, it doesn't mean that I'm expecting Germany, for example, to drop its history and suddenly shift, right? You start from where you are. You have to move from whatever that starting point is. And how do you practically take steps to make progress, right? So this is really important to understand this. And also in terms of the political context, UHC is inherently a redistributive idea to get to, really reducing the gap between the need for services and the use of services requires some redistribution. But we know that countries face limits as to how much redistribution is actually acceptable politically, how much can be done. So the key questions for me are at the bottom. What are the next things to implement that basically respond to these inequity challenges while also strengthening the foundations? So I have a way of thinking about this, and it comes a little bit as a reaction to all of the emphasis that's been given over the years on this wonderful expression called innovative financing. You've heard that. It's hard to know what it means. I've never quite figured out what it means, but what I'm trying to show, and this kind of got animated, so I will, and you can't see the top. I don't know if there's a way of getting rid of the top a bit of this thing, but I call this actually thinking inside the box, which is not what you usually hear when it comes to innovation. But the box, if you would see, is effectively the benefit package. So on the x-axis is population, and on the vertical is basically what are the services that are basically contracted, or what is covered in a sense by the purchaser, right? And the idea, well, one of the ideas is you've all seen the cube, and just it's important to recognize there had to be a rectangle before there was a cube, and I'm more comfortable with this. But the idea, and the graphic is a little bit off, is that you might have some services for everybody, right? Which is the solid blue across, which might be your, let's say, universal primary care. And then in terms of targeting, many countries have some sort of targeted program for lower income people. And the idea when thinking about different ways of thinking about your financing mechanisms is to actually say, okay, if we also have a social health insurance program, can we run that not as something in parallel to the rest of that system, but actually complementary, that effectively may either expand the services for some people or reduce their co-payments, okay? So this idea is to try to, in a sense, the real challenging innovation with multiple funding sources is getting them to work in a complementary way. Okay, so that was just a bit of that approach to the issues and how to think about this, starting with a kind of unified benefits framework. So even if you have your HIV program and your TB program, try to conceptualize them as part of your universal benefit package. Okay, now we're going to turn to some real experience from the panel, and basically just a few questions for them and for you to reflect on, right? So what is it that has actually been implemented in terms of the mix of contributory and non-contributory programs? Are they, what steps are being taken to really strengthen the foundations for universality? It's not just, oh, we've done this PBF program and now we're finished, right? What is the next thing on this? How does it lay a foundation for your future steps? Is there some explicit focus on poor and vulnerable populations? Critically important, and we saw under both contributory and non-contributory approaches, is how are general budget revenues being used? Right, this is the key. And is there strong attention to spillover effects on the rest of the system and the rest of the population? So with that, I'll turn back to Nirmala, and if I can make that go next, I seem to not be able to. But you've got it. Thanks.
And if you, thanks so much, Joe. Don't sit down because we're going to have you up at the front. And let me invite all the panelists to join me at the front. And you should keep your headsets with you because we'll be having some comments in French. And if you're in the audience and need simultaneous translation, but haven't picked up a headset yet, there's some at the back of the room. So Joe, thanks so much for not only defining these key terms and providing this macro perspective, but also teeing up some great questions for our panelists. So I'm going to start. Okay, I'll give a minute to our panelists to get their headsets. Okay, so I'm going to first start with Ibu Beki, and here ask you to reflect a little bit on the experience from Indonesia, in particular, how you combined different sources of financing to achieve 90% coverage, I think, at this point. So how has that evolved over time? And what have perhaps been some of the challenges along the way, and what you think are the priorities going forward?
the poor people, the vulnerable. And at that time, when we integrated into one, the benefit package is also varies. The rich one, the comprehensive one, is benefit package covering for the poor. And so when we negotiated with the parliament at that time, we end up by providing a very comprehensive benefit package, which may not be affordable at that time, but politically, they want us to adopt the existing, the rich benefit package. The contribution space into 3 levels. We have level for the hospital accommodation. We have for class 1, which has only 2 beds in the room, and then we have class 2, which had up to 4 beds, and then in the ward. So the poor, the vulnerable, which subsidized by the government, stay in the ward room. So then after when we start integrating, we have around 70 million population for the poor, but the government, as times goes, they expand the subsidized contribution for the poor. Up to now, it becomes 100. So the non-contributory is on the right side, and now it's about the central government pays for around 111 million people, and then another 40 million for the for the poor, but subsidized by the local government. On the left side, I think it's a contributory. We have an employer base, which based on the percentage of their salaries, 4% come from the employers and 1% is from the employees. And we have also private employers, covering the employees with the family. In addition to that, we also have quite a big informal members, and this informal members is quite large, and we have covering about 30 million right now. And this is the challenge of collectability. We have very difficult in collecting the premium for this. Up to now, it's only around 50% are paid for the contributory. We still have challenge. And then since we have to matching between revenues and spending, and as you may aware that in the operational we have some deficit, and then in 2018 the government adjust the premiums, increase the premiums, and also since we don't want to lose the informal members, so the government pays subsidies to the informal members by paying 17%. So that is the efforts that the government subsidies place in terms of ensure that the coverage are still high. So up to now, we are still in the process of reforming a standard hospital class. We are not want to have a three level of hospital accommodation. We want to set it into only one, but again, the parliament argument with the parliament, they still want to not want to be in the one room with the vulnerable. So in the process, we will change it into two class, so employer-based and subsidized, non-contributory. So hopefully, and up to now, we are already coverage about 90% of the population. We have 270 million people. Of course, there is a lot of challenge in the future, but with the Ministry of Health now is also trying to improve the supply side. From the supply side, health manpower is not equitably distributed, and we are trying to deploy some of the doctors and specialists and also health equipment, so access for a certain disease can be utilized by the members. I think that is my presentation. Thank you.
Thank you so much, Ibu. I think that's a great example of many of the themes, Joe, that you were emphasizing, both, I mean, fundamentally starting from where you are and trying to bring together different schemes and different financing sources to build towards universality. I think Indonesia is a great example of that. And so we'll now shift gears a little bit and hear next from Edwin. Edwin, you've looked at evidence, of course, from all across Africa, and then you're from Kenya, which has one of the oldest social health insurance schemes on the continent. So I wonder if you could draw on both your research on both of those settings to talk about the potential as well as the pitfalls associated with building national health insurance in African countries.
Thank you. Thank you, Nimala, for that. So I'm going to talk about, rather draw from two experiences, as you've mentioned. One of these is a study that we carried out about 2 years ago, looking at health insurance coverage across African countries, using secondary available data, so DHS data, and you're able to get that from 33 African countries. And there are a couple of observations that came out of this analysis. We were interested in looking at both the level of health insurance coverage, so this is the level of population enrollment, and secondly, looking at inequalities in health insurance coverage. And then we looked at other things beyond that. And the key findings really are that, number one, generally across the African countries, the 36 African countries that we looked at, the level of enrollment was quite low. So on average, the level of enrollment was about 8%. But of course, this ranged from among those countries that had some form of health insurance, ranged from as low as 1% all the way to a few countries that had, so the highest country had about 80% at the time. But then when you look at the actual distribution, then only about four countries had coverage above 20%. So really, most of the countries had quite low population enrollment, which tells you something about the capacity of contributory health insurance to scale in a context like Africa. The other thing we looked at is the sort of distribution of this enrollment. And again, here, the key finding was that enrollment to health insurance schemes across these 36 countries was characterized by pro-rich inequalities. So typically we would assume that, especially when you talk about publicly funded health insurance scheme, we'd assume that they majorly cater for, quintile 1, or, the lower quintiles of, people that are lower down in the socioeconomic status. But what we actually found is that these schemes are substantially pro-rich. So, looked at these in many ways, but the most intuitive and simple way to look at it is just to look at what proportion of people that are covered are in the 5th quintile, so the richest quintile, and what proportion are, in the 1st quintile, so the poorest quintile. And so when you do that ratio, on average, quintile 5 was sort of over, enrolled 4 times more than quintile 1. That's on average across the continent. But again, that average, hides a lot of variation. So a lot of the countries, so for instance, in a country like Nigeria, that ratio was, 348, so essentially meaning that scheme absolutely doesn't, it's quite negligible the extent to which it has anyone in quintile 1. And most people are distributed actually in quintile 5, not even quintile 2, 3, and 4. So the inequalities there were quite high, which tells you again that at least in this continent, these schemes haven't been very good at being pro-poor or thinking about people at the bottom of the pyramid, as some people would call them. When we think about financing schemes, there are certain objectives or rather certain metrics that we'd like to measure them against, and one is their potential to raise revenues for the health sector. And again, within the African continent, on average, the contribution of contributory health insurance to total health expenditure is quite low. So on average, it's about 5%. So lots of investments going into setting up these big bureaucratic entities, a lot of human resource allocation in terms of resources and time and so on. But in the end, when you look at their contribution to total health expenditure, it's quite disproportionate to all the hard work and the effort that's going into setting them up and maintaining them. So those were really the findings from this work. But having said that, like I said, we have some countries within the African continent that have managed to get at least health insurance enrollment to high levels. So we had about 4 countries that had above 20%. 20 is not a very good number, but in a context where everyone is doing badly, then the threshold is the bar is a bit low. We have countries like Rwanda and countries like Ghana, which have done much better in terms of enrollment. At the time we were doing this coverage in Rwanda, for instance, which was the highest, was about 80%. Now I understand is only it's close to 90 and going up. We have Ghana as well. Coverage is now about 70%. Gabon is also doing quite well. And one of the things about these countries is that, one, they were characterized by high enrollment, so they were outliers in terms of enrollment. And second, they were also characterized by low inequalities. So within these countries, these schemes were actually substantially, or rather much better distributed across the socioeconomic quintiles. And one of the things that characterizes these countries is that these are also the countries where these schemes have substantial budget support. So in Ghana, in Rwanda, in Gabon, these are schemes that have substantial budget support, which distinguishes them quite a bit from the rest of the countries where there's a lot of reliance on sort of individual premium contributions from formal and informal sector. So that tells you something about how you structure the financing of this, of these financing mechanisms to achieve some of the health system goals. But having said that, we also have to think about other things like financial sustainability, for instance. And I think we've heard from Indonesia that financial sustainability has been a challenge. So once again, in as much as these countries are outliers, so Ghana is an outlier, Rwanda is an outlier, analysis of their financial sustainability points to challenges, in terms of the long-term financial sustainability of some of these schemes. So, it's not just sufficient to allocate budgets to them. We have to think about whether those budgets are matched with the actual needs and the promises you're making to the population in terms of what you want to purchase on their behalf. So that's what came out of the findings from this sort of study across 36 African countries. So I'll pivot a little bit to talk about Kenya, and I think Agnes started her introduction by talking a little bit about this. So Kenya has had a public health insurer known as the National Health Insurance Fund. The name changed recently. Previously, it was a National Hospital Insurance Fund. I think it's the oldest insurance sort of public insurer in the continent, unless someone raises their hand and says otherwise. It's been around for more than 60 years. Over this period of time, the scheme has evolved quite a bit. So had quite a number of reforms around the population that is eligible to for enrollment. So previously it was only formal sector. Over time, this was expanded to include the informal sector. And again, over time, there was a sort of intentional effort to target subsidies at the poor, people who cannot afford, so that they can also be enrolled through budget support. Other reforms have included, reforms around the benefit package. So at the inception of the fund or the scheme, the focus was mostly on inpatient, inpatient services. There has been an expansion of those services, and also, to include other services, but to also include outpatient care as a reform. And the other important reform has been around premium reform. So an increase, a progressive increase in the level of premiums, and including recently, there's a proposal to increase it much further. When we think about its performance, it's a mixed bag, but I'm going to talk about its performance across sort of a range of health financing functions. So when you really think about its revenue mobilization performance, it has, the NHIF in Kenya hasn't done a very good job at mobilizing resources for the health sector. So for a very long time, its contribution to total health expenditure stagnated at around 5%. Now it's sort of going closer to 10%, but still quite low. So it hasn't done very well there. And for a number of reasons. And part of it is really because, the contribution mechanism is largely voluntary, because we have a huge informal sector. And like the case of Ghana and Rwanda, analysis has shown that it is financially unsustainable. So the numbers, essentially the scheme is in the red. The numbers aren't looking very good for it. With regards to its ability to pool risks and resources, again, the scheme hasn't done a very good job here. Enrollment numbers have remained quite low. For a very long time, it was between 10 to 20%. Recently, we had new estimates putting it at about 24%. So still quite low there. The pools are quite fragmented, have been quite fragmented. So last analysis, had about 85 pools, which is a bit ridiculous. And essentially it's, the pools are divided across the general scheme, which covers everyone. Then you have enhanced schemes, which cover civil servants and other privileged individuals, which enhances the inequities. And we see a lot of inequities there. It's characterized by a lot of adverse selection, so we, at last analysis, the payout ratio, especially for the informal sector scheme, was about 300%. So for every sort of shilling that an informal sector person contributes, they take out 3 shillings from the scheme. There has been a focus on pro-poorness, so trying to allocate budget resources to really target the poor in terms of providing subsidies, but this has faced quite a number of challenges. At last analysis, inclusion errors were quite high. So people that were categorized as poor, 40% of them fell between quintile 5 and 4. So most of them were actually rich. So the rich were capturing the benefits that were intended for the poor. The scale has been low, about 1 million households out of possible 4 million households. And utilization has also been low because of challenges with getting the poor to change their health-seeking behaviors. There are a number of purchasing challenges, which I'm not going to get into right now. But I'd just like to also, highlight operational and governance challenges. So, these large schemes tend to mobilize resources that attract corruption. So, the scheme has had that as a problem, and operational efficiencies. So essentially, that's really the performance of the scheme. And I'd just like to stop by saying, so really, when we think about structuring these financial instruments, on the one hand, we have to align them to our policy goals, but on the other, we also have to align them with the context of the countries. What is the context of the country? And, we've talked about this, a lot of countries in low and middle income countries have high informality and high poverty levels. And, Joe has talked about aligning it with the fiscal capacity, but the other capacity that we need to think about aligning it with is what I would call bureaucratic or policy capacity. What is the capacity of the countries to actually implement these complex organizations that are being given complex functions? So we really have to think about that as we structure these financing arrangements. Thank you.
Thanks so much, Edwin. Lots of interesting insights in that. The last one in particular about capacity and policy capacity, bureaucratic capacity, I think sets us up well for our next panelist. You may need your headsets to hear Dr. Pierre's response. So Dr. Pierre, Burkina Faso has, of course, a successful non-contributory scheme, the Gratuité program that replaces user fees for maternal and neonatal health services. And it's also pursuing a social health insurance scheme. And so I was curious if you could reflect a little bit on first, the successes of the Gratuité program, as well as the challenges, and why this decision to also pursue a contributory social health insurance scheme, and what's been the thinking in terms of bringing the two together. Cool, thanks.
OK. Merci bien, Nirmala. Et merci à tous et à toutes. Je vais essayer de parler lentement pour permettre aux traducteurs d'être fidèles au plus possible, parce que traduire aussi, c'est trahir. Mais bon, j'ose espérer qu'on va y arriver. Alors, concernant le mécanisme de régime non contributif du Burkina, couramment appelé dans notre langage gratuité des soins, je voudrais juste signaler que c'est un processus qui a pris beaucoup de temps au niveau du gouvernement, et rapidement rappeler que entre 2006 et 2015, nous avons pu expérimenter d'abord la subvention pour les femmes enceintes et les nouveau-nés. Il s'agissait en fait d'une initiative qui a visé à mettre en moyenne 3 milliards de francs CFA par an, c'est-à-dire qu'à peu près 5 millions de dollars par an, pour que les femmes viennent accoucher en payant à peu près $1, c'est-à-dire un copaiement. Et c'est le gouvernement qui complétait. Et pendant les 10 ans de mise en œuvre, il y a eu des acquis, mais nous nous sommes rendus compte qu'il y avait toujours des populations qui n'avaient pas accès. Et quand on a regardé l'évolution des comptes de santé, nous nous sommes rendus compte que le paiement direct des soins était la première source de financement de la santé, et suivi des ressources de l'administration publique. Et dans le même contexte également, et pour ce qui concerne l'assurance, c'est-à-dire la couverture maladie, on était toujours à peu près à 2% de la population couverte. Et fort de ces deux constats, à partir de 2016, le gouvernement a pris l'engagement d'établir ce que nous avons appelé un pacte pour la réduction de la mortalité maternelle et infanto-juvénile. Et ce pacte a consisté en quoi? Ça a consisté à lever directement la barrière d'accès aux soins de santé pour la femme et pour l'enfant de moins de 5 ans. Une décision qui a été prise en 2016, conçue en 2016 et mise en œuvre depuis avril 2016 jusqu'à présent. Ça fait 8 ans. Et qu'est-ce que ça contient? Ça contient un panier de soins que nous avons identifié et le panier de soins a été progressif. Initialement, nous avons visé un certain nombre de prestations de maladies pour lesquelles, si les populations ont accès directement, ça peut réduire d'au moins de 80% tout ce qui est décès, tout ce qui est morbidité. Donc, entre 2016 et 2019, nous avons enclenché ce dispositif et en 2019, nous avons ajouté dans le panier de soins la planification familiale et les soins au niveau communautaire, de sorte à ce que si la plupart des femmes en âge de procréer ont accès aux services de planification familiale, l'évidence montre déjà qu'on a une réduction ou du moins une contribution à la réduction d'au moins 30% de la mortalité maternelle. En 2022-23, le panier de soins a encore connu une augmentation avec pour focus de pouvoir réduire les évacuations sanitaires hors du pays. Donc, nous avons inclus à partir de 2023 tout ce qui est en rapport avec la radiothérapie qui coûte extrêmement cher, visant surtout la femme dans le processus. Cancer de sein, cancer du col et pour toute population vulnérable. Donc voilà à peu près comment nous avons évolué le panier de soins gratuits et je dois vous préciser que ce n'est pas encore fini parce que c'est un engagement politique fort et que nous sommes en train de voir pour les personnes âgées. D'autant plus que personnellement aussi, je tends vers la personne âgée. Il faut aussi regarder à partir de 60 ans, nous allons inclure peut-être d'ici 2024 toute cette population pour avoir accès aux soins gratuits. Les réflexions sont déjà avancées. Le quitus, le feu vert a été déjà donné par le gouvernement. C'est à nous techniciens de réfléchir pour voir l'enveloppe financière disponible et puis corrélée avec l'accès aux soins. Donc voilà à peu près résumé les grandes étapes en 8 ans et nous avons remarqué qu'il y a un fort engagement qui a fait que le gouvernement a pu mettre à la disposition des formations sanitaires à peu près 375 millions de dollars en 8 ans sur des... les factures, c'est 325 millions de dollars et le gouvernement a pu payer 195 millions de dollars. Ça veut dire que le taux de paiement est d'environ 87%. Donc, c'est pour dire qu'en termes de défis, on n'arrive pas à couvrir à 100% les factures qui sont émises par les formations sanitaires. Mais cela aussi est un peu lié au dispositif qui est mis en place actuellement. Pour les défis, je pourrais dire que au-delà de ce que nous avons eu comme acquis, je pense que récemment, on a fait une projection. On a vu que l'utilisation a beaucoup augmenté. On a vu que ça contribuait à baisser les décès maternels et les décès infantilo-juvéniles. On a vu que avec cette politique, les paiements directs des soins, ça ne constitue plus la première source de financement de la santé depuis 2016. Aussi, une grande réduction des dépenses catastrophiques de santé. La publication va sortir incessamment parce que nous avons pu regarder avec Finkwell et avec l'Institut national de la statistique quel est l'impact sur les dépenses catastrophiques de santé. pour les challenges et les défis. Il s'agit pour nous surtout de pouvoir maintenir cette politique de gratuité. Et ça, c'est un acquis. Et quand on regarde le pourcentage du budget alloué au ministère de la Santé, on était autour de 14%, très proche de la déclaration d'Abuja. Avec le contexte d'insécurité, de terrorisme, le gouvernement a toujours maintenu comme priorité. C'est vrai qu'on a diminué à peu près 12% pour cette année, mais c'est toujours un engagement et une priorité pour le gouvernement d'allouer des ressources pour la politique de gratuité des soins. Le deuxième défi, c'est que nous nous sommes lancés dans une réforme visant l'efficience. C'est dire que effectivement, on a en moyenne 54 millions de dollars par an pour soigner gratuitement selon un design qui est simplifié, qui responsabilise les formations sanitaires. Mais en regardant de près, on peut encore faire mieux si nous activons 3 leviers. Le premier levier sur lequel nous sommes, c'est de pouvoir mettre en place ce que nous appelons la feuille électronique de soins, de sorte à ce que nous puissions créer un écosystème digital minimal pour pouvoir effectivement traquer tout ce qui est soins gratuits offerts et pouvoir regarder et être plus efficient. Le deuxième défi, c'est le régime contributif qui est en cours de développement et c'est ça la deuxième question de Nirmala, même si elle me dit qu'il me reste 2 minutes, je pensais qu'il restait 20 minutes, mais bon, juste pour dire que en réalité, pour le régime contributif qui est en cours de développement, nous travaillons avec le ministère en charge de la protection sociale. Je précise que pour la gratuité, c'est géré au niveau du secteur santé et pour l'assurance, c'est géré au niveau d'un autre département ministériel. Et l'architecture qui est presque finalisée, c'est que nous n'ayons pas 2 acheteurs de soins parce que dans le régime contributif, c'est une contribution pour le ménage, pour la famille. Et comme les enfants et les femmes font partie de la famille, nous avons convenu de pouvoir fusionner. Et mon travail actuellement, c'est de transférer la gratuité des soins au niveau de la Caisse nationale d'assurance maladie pour que non seulement on puisse assurer la durabilité et la pérennité en complément de ce que l'État donne, et aussi pour éviter la fragmentation au niveau du système de santé. Pour conclure, même à ressources financières limitées, nous pensons personnellement qu'on peut impulser la marche vers la couverture santé universelle si nous arrivons à opter pour des choix qui sont vraiment adaptés au contexte du pays. Je vous remercie.
Thank you so much, and apologies for, we can, of course, hear so much more, and I'm sure we'll come back to hear more during the question and answer section. So I want to turn swiftly to Tanzania, and Gemini, hear from you how Tanzania is thinking about bringing together different schemes. My understanding is that the country is trying to build towards a unified national health insurance scheme, but at present, there's the national NHIF, the National Health Insurance Fund, that's running a contributory social health insurance scheme, as well as the Community Health Fund. And so what's the current plan for bringing these together and building towards a more integrated systems approach?
Okay, thank you very much, Nimala. So as a background, yes, in Tanzania, we have 3 main public sector schemes. The first one is the general budget, which is comprised of 2 sources. It's the general taxation, but also we have a health sector basket fund, which this pull together the resources from the development partners who have special interest in to finance the health sector. And then we have two contributory schemes. We have the National Health Insurance Schemes, which is for the public sector, public employees. It's a mandatory scheme for the public employees with a voluntary option to enroll for other. But also we have the Community Health Fund, which is a scheme targeted to the informal sector, and it is voluntary to all. So the enrollment at the moment of the two schemes is estimated at 15%. The poor who cannot afford to contribute in these two schemes have exemption. We have the exemption policy. They access free healthcare in the public facilities. So with this setting or with this arrangement, there are a couple of challenges that the system has already realized. The first one is the differences in the packages in these two contributory schemes. We have the National Health Insurance Scheme with a very high level of benefit package up to the national referral hospitals, but also including all the private facilities. But the community scheme is mainly limited to the public facilities, and it's mainly you can only access the primary services. Although recently it has been reformed to include some of the regional hospital level services, but due to its lower level of premium contribution, it's really difficult to guarantee access or to provide services for the community health fund members at the regional hospital level. But also we see that because of the voluntary nature that has been introduced in the National Health Insurance Fund, there's a sustainability risk that has been introduced there, because this scheme is providing a high level of benefit package. So the high risk groups are willing to enroll there voluntarily by paying that level of premium that has been set, but their level of consumption is too high, which is risking now the sustainability of this scheme. But also the exemption policy that has been introduced by the government is really not working, because the poor are expected to access services in the public facilities, but these services, and there is no funding that is earmarked to finance the services that are accessed by the poor. Of course, the claim that is being put forward is like the government is already financing the human resource in there. But what matters in the provision of services is the operation funds. So you have always the poor accessing, but that is contributing to stock out. Most of the time you find the PHC facilities without the drugs. So with these challenges, the government decided to adopt a reform, and the entry point of this reform was more on the side of the collection and the pooling part. So one of the major proposed reform was to harmonize or to integrate this public sector, the two public sector schemes, the National Health Insurance Fund and the Community Health Fund, into a unified single national health insurance. But at the same time, harmonize the benefit package between the formal and the informal sector, so that all people can have the similar access. But at the same time, the Ministry of Finance is also asking for the central public resources to be pulled into this single fund, so that the poor can also be enrolled through the public financing. This reform was initiated in 2012, and it has taken too long, because there's a couple of challenges that have been observed in the process. The first challenge is emerging from, I think I would say it's a wrong foot that we started with when we introduced the contributory schemes. We had this NHIF, which is an agency under the Ministry of Health. And then we have the Community Health Fund, which is under the Ministry of Local Government. So there's already a fragmented management systems in the management of these two pools. Harmonizing them into one pool is bringing challenges, because like the Ministry of Local Government thinks like, okay, this scheme is continuing, is targeting the community, and it's the fund that initially was going through the local government budget. So in a way, it's kind of losing resources on that side. So that kind of tension is one of the aspects that has delayed the process of integrating. But also there's a worry from the members under the NHIF, because this is a scheme that has been there for quite a long time. And then you are bringing the informal sector into this unified mandatory scheme. So the feeling is like, okay, you're going to introduce, like the sustainability of NHIF is at risk at this point. But also, up to this point, the Minister of Finance has not yet committed, like have a firm commitment of the public resources to be allocated into this unified pool. So the reform is taking long. Those kind of negotiations and discussions are still ongoing within the government. And having recognized these, the Minister of Health thought of introducing some of the intermediate reforms while we are waiting for this longer-term reform. And one of the major reforms that was introduced is to take the entry point of improving the strategic purchasing. So improving efficiency in what is existing. And the immediate step that was taken in 2017 was to introduce the direct facility financing. So the Minister of Health, with the negotiation with the Minister of Finance, but also in collaboration with the partners who are financing the health basket funding, decided to change the modality on how this non-discriminatory public health sector basket fund is allocated to the health sector. Initially, it was allocated in a line item budget as the other public funds. But in 2017, the decision was taken to send the health basket fund directly to the primary healthcare facility bank account. And so it was, we developed a capitation formula that is used to disburse the health basket fund directly to facility bank accounts. And this was a system-wide approach because it was a reform that was introduced across all public facilities. And what does this mean in terms of the system improvement? With the introduction of direct facility financing, we see now the public primary healthcare facilities have at least resources to be able to provide services. They'll be able to stock back the medicine when they're running out of stock. And with this initiative, we are starting to see now the exemption policy is at least starting to work. When the poor are visiting these primary facilities, at least they can get access to the medicine or the drugs that are available in there. And there are also an improvement in terms of equity, because you will see with the contributory scheme, especially with the National Health Insurance Scheme, people are mainly accessing the private health facilities and the higher level referral hospitals in the public sector. But the only few who are accessing primary health care. So the primary health care, the public primary health care facilities are not benefiting from the reimbursement from the NHIF. So with the introduction of DHFF, at least it's helping to cover the revenue gap across the public primary facilities. And the other reform that is in line with the DFF, building on the experience of the capitation that has been introduced under the Health Basket Fund DFF, we are also harmonizing the provider payment mechanism across the existing health insurance schemes. So with the Community Health Fund, with the little resources that are currently being collected, what has been done is also to adopt a capitation payment mechanism under the Community Health Fund. So at least the money that was initially budgeted in the normal line item budget is now flowing directly to facility bank account. Similar reforms are also ongoing with the National Health Insurance Fund, at least to have a formula that will guarantee the allocation of capitation grants across all the public primary health facilities. So the major message in here, while we are looking at this longer-term reform in terms of introducing contributory scheme with the government subsidy for the poor, it's not an easy reform to introduce. We need to keep on thinking in terms of how we can exist efficiency based on what we have. I think that's the route that the government has decided to take in Tanzania as we are waiting for these political debates and the discussion in the introduction of the broad mandatory national health insurance scheme. Yep. Thanks, Nemala.
Thank you so much, Gemini. I think that's a great example, again, Joe, of what you were talking about, even as you aspire for an integrated approach that brings together these disparate schemes. How do you start laying the foundations in the short to medium term to build towards that vision? So I know we've gone a little bit over in terms of time, but let's take a few questions. Agnes, my colleague Agnes at the back, has a couple of mics. If there are any questions for our panelists, please raise your hand. I think we have one So let's start with the gentleman at the back, and then we'll come to you in the front, and then the lady at the back. Introduce yourself, and I do urge you to make it a question. Sorry, I'm going to just come back to you when they have the mic ready. Because of the interpretation, we can't have you speak without a mic.
See, there's someone in the back there. He's working.
Okay, start with him and then if we can just check the mics.
Okay, thank you. Good morning, everyone. My name is Simeon Onyemechi. I work for Anambra State Health Insurance Agency in Nigeria. Beautiful presentations across the table this morning. My question will go to Gemini and then to Edwin. For Gemini, I appreciate the fact that there are reforms being introduced to actually tackle the issues, precisely with this push towards DFF, which we spent a lot of time yesterday really deliberating another section. Now, I want to know, the move is towards capitation, and then this is at public facilities, primary level care, when individuals have need for secondary care, because we're talking about equity now, getting needed services. Yes, we understand 80% of services that are needed can actually be offered at primary level, but when they do really need those services that have to go to regional and specialist facilities, how will that be paid for, since we are pushing towards capitation? Is there, yeah, I just leave it at that, and then I want to hear about that. Then for Edwin, very wonderful presentations from yesterday, the session you moderated, brilliant. I just am thinking, when you talked about where Kenya is today with regards coverage, I know, yes, indicators coverage doesn't really come up to universal health coverage. However, looking at the resources I see in Kenya, technical resources, I'm actually wondering, what are the real issues why Kenya's coverage rate is at the point where it is from what you have said? Because across the table and across the rooms I have been in, very rich resources in Kenya. Is there any contextual issue why that has not, that technical capacity has not been translated to action that we need to learn from? Thank you.
Okay, so let's go to the lady at the back, and then we'll have one more question, and then I'll come back to the panelists.
All right. Good morning. My name is Bolanle, work for Abt Associates in Nigeria. Good to have you here, Germany. And my question is for you. I wanted to clarify for me the resources from the development partners. You mentioned a basket where you pull resources from the development partners. What form does this come in? Are they paying premiums for people? Is it a collective pool that they all put money in and then the country, uses that to cover people? Can you clarify for me? And also you mentioned the budget-based contribution. Can you also clarify that? And then how do you collect premiums from the informal sector? Do you have a strategy? I know you mentioned lots of challenges right now, but what is working in your approach to collecting premiums from the informal sector?
Thank you. Thank you so much. Did you still have a question? Yes. No. Right here, sorry.
Thank you. My name is Fitson from Ethiopia, and my questions are directed to Tanzania, our colleagues from Tanzania and Indonesia, because these two countries are aiming towards harmonizing their insurance scheme. And we in Ethiopia, although we currently have one insurance scheme, but we are eyeing to have an integrated insurance scheme of more than two. So just wanted to know how you entertain the idea of equity when you integrate these two insurance schemes. Because as you've mentioned, the three insurance schemes have different enrollment or contribution rates and different benefit package. So as you're considering non-contributory insurance approach, how do you entertain equity? Because all citizens are entitled to the benefits of the government, and how do you entertain that? Maybe related to that, I just want to understand more about your communication strategy towards integrating these insurance schemes, considering that they have different benefit package and contribution rate. How was your communication strategy with beneficiaries or healthcare providers? My other question is to my colleague from Kenya, and you mentioned about the study conducted in several African countries, and I was keen to know more about the strategies that countries have adopted in injecting more resource to these to the subsidies or those to the non-contributory insurance scheme, particularly in Ethiopian context. Our community-based health insurance scheme has done remarkable job as far as enrollment is concerned, and despite all the success stories, this is also affecting the government subsidy to those who can't afford. So just wanted to know how other countries have experienced this and what coping mechanism they have in set.
Thank you so much. Okay, so we have a bunch of questions for Edwin, Gemini, and then Ibupeki. So Edwin, would you like to start us off?
Yeah, thanks. So I had, I think, two questions. I'll start with the question from Simon, which is a very interesting question around why is it that despite, if I interpreted your question correctly, the presence of technical capacity, that hasn't translated to substantial sort of reforms on the ground. And I think this is a big issue, really. I mean, the issue in Kenya, as I suspect in a number of countries, is not that the technical solutions are not known. I think people know about the solutions. The question is, what is the practical feasibility of implementing those solutions? And for me, the issue in Kenya is a political issue rather than a technical issue, right? So, we've said this in the past. There's a sense in which the National Health Insurance Fund in Kenya, suffers from what I call policy capture. So it's essentially been captured by several interest groups. So we have politicians who have been historically unwilling to implement substantial reforms because the NHIF is a good target for rent seeking. So any reforms is likely to compromise that interest. We have the private sector, which is unwilling to support substantial reforms because it benefits from the current arrangement. So 80% of benefit payments, claims payments, go to the private sector from a public insurer. So private sector will not be interested in some of these reforms. And then we have elite groups now. We have civil servants and other formal employees who benefit from enhanced schemes, so enhanced benefits, who mount substantial resistance whenever there are attempts to things like harmonization of benefit packages and so on. So really, it's policy capture of the institution. There was a question around examples of what countries have done to mobilize resources for subsidies. So other than just, sort of general budget allocations, we have several examples, especially among the countries that have higher coverage. So Ghana, Rwanda, Gabon, and so on, of earmarking of taxes. What I think Joe was alluding earlier to, so they're labeled innovative financing, whatever that means. But the idea is to try and look for opportunities to earmark some funds to the national health, or rather to your health insurance scheme. So Ghana, for instance, earmarks, a part of its VAT and a part of its social security contributions to the scheme. Rwanda has a raft of, earmarked pretty much, very many things, including tourism and so on. You have some percentage that goes into the health insurance scheme. So many examples of earmarked taxes that have been used to provide financing for subsidies.
Gemini, do you want to go next?
Okay, thank you. So have like 3 questions to respond. So on the capitation issue, so first, our definition of primary healthcare, it starts from dispensary health center and district hospital. So at least we have some hospital elements under the capitation. So this is where the Health Basket Fund, DFF is targeting, and you'll see it's already covering like a wide population. The good thing in Tanzania, the referral hospital, at least from the regional up to the national hospital, at least the focus of the government is good. They're getting operational fund from the central budget. So at least at that level, the problem is not that huge compared to what was the situation in the primary facility. So when you're going there, if you're not under the health insurance, the exemption policy still applies. And if you have to that level, that means that's a serious case. So basically you will be able to get some access in there. For from my colleague from ABT, there is a question on clarification on the Health Basket Fund. So the Health Basket Fund, the way our central budget is working, we have the general budget support, the main source, one of the sources, the general taxation. And then we have the development partners who are supporting the budget, just an earmark, the general budget support. And then we have some of the partners who are specifically supporting the health sector, but they are not going to program financing, but their support is through the treasury system. So the non-earmarked partner support goes under the general. It's like you can earmark, it's allocated like the general taxation. But for the health sector basket fund, that has to go to the health sector. So this is the portion that the government decided to allocate directly to the frontline service provider, rather than using the line item budget support that was used before. And for the informal sector, it's the same challenge that we are facing, similar to other countries. The country has tried to be innovative, like identifying some of the sensitizing team at the lower level, at the village level. They have like 2 people who are working around house to house, trying to mobilize people to enroll to that. Since this is still voluntary, we are still facing the challenges. We are thinking moving forward with a unified scheme to introduce the mandatory. And the thinking that is there is not getting political support that much, is to attach enrollment to insurance with other public services. Like if you want a driving license, some of the proposals that were coming, if you want a driving license, you need to show us your health insurance card, but also business licenses. But there are a couple of public services that have been earmarked. But at the moment, there's a high level of political resistance. It seems like it's not going to be operational anytime soon. For how to address equity, so the proposal at the moment, because for the formal sector, the premiums are going to be progressive according to income. For the informal sector, it's challenging to do that because you can't identify the income level. So the initial process is to have like the flat contribution for the informal sector, but over time, continue establishing the database. At least the thinking is to go to a similar structure like what Rwanda has done. That's going to take us a long time to do. But for the poor, is to tap the subsidy from the government. So at least the government to allocate tax resources into the pool to finance the poor. So we don't expect the poor to pay for the health insurance. Yeah, so that's, and on the benefit packages, to harmonize the benefit package across all the members. Thanks.
Thank you so much. I know there was a lot, and we will have opportunities in the remainder of our morning session to get into some of these issues also in small groups. So Ibubeki, really quickly, your response?
Yeah, thank you for the questions. So yeah, the benefit package is different, and the poor are the one who is having access with very comprehensive. Comprehensive means actually the 3 schemes has a good benefit package, but there is the poor are the one who's covered everything, even until advanced open heart surgeries or something, but the other are not covering. So when we integrate it and we adopt the most comprehensive one, I think they are happy for that. And we are also adjusting the capitation, the payment mechanism. We pay the hospital using a CBGs and then primary care with the capitations. And we also have adopted the National Formularium of Drugs. Previously, the employer base using more generic drugs, and the poor are generic. Now we mostly adopt the generic drugs. If the rich or the employer do not happy, then they buy a supplemental insurance for that. But since the social health insurance the foundation is for the basic health services, so we provide with the generic drugs and using the referral systems, and put the primary care as the front line. Thank you.
Thank you so much. So we've obviously just gotten started thinking and applying, Joe, the questions and the framing you provided in the beginning to sort of look under the hood in each of these countries and understand the complex issues, the complex financing landscape, and how you tackle some of those principles in the context of politics, in the context of economic challenges, et cetera. I know I've run into the coffee break, and I do know there were lots of questions in the audience, but since I don't want you all to miss out on the coffee, what I'm going to suggest now is that we take a 15-minute coffee break. You just pick your coffee and come back, and I'll assure you that in the second segment, we have time for group work, during which you'll also get to ask and discuss many, many of your questions with these panelists and more. So the coffee is outside. Let's go grab it quickly and try and be back in 15 minutes so we can start by 10:35. Thank you. And let's have a round of applause for all our panelists.
Welcome back to part 2 of this session. Thank you to anyone who's just come in from another session. We welcome you. I'm sure you'll be able to catch up from the discussions we had earlier. And thank you to Namala for facilitating a stimulating discussion with Edwin, Gemini, Ibu Becky, and Dr. Pierre. And thanks, Joe, for that insightful framing of this discussion. So, great, we're just settling down. In this second half, we wanted to hear from 2 countries, building on from our first conversations where we had varied experiences on contributory versus non-contributory schemes, and some of the successes that have been made so far, some of the challenges, and just giving us food for thought as we think of our design options back home. And I think one of the things we've tried to keep front and center is that regardless of which way we go, we want to keep in mind our goals of achieving UHC, that everyone has access to good quality health services without financial hardship. And we might argue about who is everyone. When we talk about everyone, what do we mean by good quality services? What services, all services, some services? And what we mean by financial hardship. Is it no out-of-pocket expenditure? Very hard to achieve that, but can we reduce it? And I really like the slide that Joe shared comparing China and Thailand that made similar decisions, but because of how they designed their schemes, the insurance schemes, that they didn't quite achieve some of the reduction in financial hardship for the population. So seeing out-of-pocket expenses still going up in China, but in Thailand coming down. So I think we're all settled. I was just talking through and making sure everyone's fine. And we have 2 speakers, as I mentioned. One is Grace Achungura. Grace Achungura comes from WHO in India, and she will be sharing her perspective from her work in India and giving us interesting perspectives in what led to the design decisions that were made, the political context for them, what they've achieved so far, and the unfinished agenda in India and how they're working towards that. And then similarly, we'll have a presentation from Martin Sabinoso, who was a former Deputy Minister of Health in Argentina. I never fail to hear something new when I hear from Martin, and he'll be talking through Plan ASE and Plan Sumar in Argentina. And I think both contexts provide some interesting insights. Again, not framing one as good and the other as not good, but really thinking of the context and how they've been able to adapt and build from where they are and move forward. So we'll start off with Grace. Yes.
Thank you, Agnes. Hi, everyone. Good morning. I'm the health financing lead at the country office for India, WHO, where we work a lot with the government on the PMJ reform. I'm going to be looking at the use of the information systems, the reforms that have taken place over time, and how they have taken us along the journey of scheme to system, function to broader health system, and the political underpinnings of that, but also the achievements and then the unfinished agenda. So I would say that the big bang reforms really around the information systems in India commenced around 2008 when the government, through the Planning Commission, then started the unique identity number, ADHA. It's a 12-digit number, very randomly selected numbers that are used to identify and confer proof of residence on citizens, but also foreigners who have spent a certain period of time in that country. And that number is used across the board for guaranteeing benefits, for registration for different purposes. Along with that, other reforms came around payment systems, financial payment systems, digital systems, DigiLocker, which is a mechanism for storing your documents online, e-rupee, another payment mechanism, and so on and so forth. So that digital backbone that commenced around 2008 has framed the basis for a lot of reforms within the health sector, but also across the government. On the back end of this, we were having also health financing reforms. So they started off with RSBY, which was a government subsidized insurance scheme, largely for secondary, tertiary hospital care for the below poverty line people, providing cashless care for those services for a household of 5 people at 30,000 Indian rupees. And the way that was managed was largely through third-party actors elected at state level through using public-private insurance providers who would manage the scheme, beneficiary enrollment, claims management, grievance redressal, and so on and so forth. And these ones, of course, they would put in bids, but these bids were for select districts within the states. And then, so what that happened is that within the system, you ended up having smart cards that were used for beneficiary enrollment that were under the purview or in the hands of the beneficiary, but then claims management, beneficiary enrollment systems that were within the purview of the separate insurance schemes, tagged, of course, to the state authorities and the central authority, but largely the data lying with the insurance schemes. And so a bit of fragmentation in the information systems, data availability or variable quality, a lot of gaps in the data. So limiting decision-making as well as public availability of the data. So one of the things that then came when the current government was looking to reform insurance in the country, that was around 2018, they decided to set in place PMJ, which we all know, the biggest scheme covering 500 million people to a cover of about 7,000, USD household. And so with that scheme, when that came, they adapted one of the insurance schemes in Andhra Pradesh. They had a unified information management system for their scheme. So the central government adapted that one at the central level to form now what we call PMJ's TMS. That one has the beneficiary identification system module. We have the hospital empanelment module, which originally was more manual and paper-based, but now has been digitalized. And we also have the transaction management system, which is also digital. And then the grievance redressal is on there. The fraud alerts and anti-fraud, anti-abuse is also on the PMJ system. Now that one has been used across pan-India for all the states. A few, maybe 3 or 4 states are using their own that they had before, but largely we are using PMJ's IT system. What that system has now uses ADHA, the cross-government identification system, to identify beneficiaries using a nationwide database on who is poor. So that has improved the targeting. Previously with RSPY, we're having a lot of inclusion errors and exclusion errors, but now we have more. We did an assessment with 2 states and we saw that we are having less inclusion errors as well as exclusion errors. So that beneficiary targeting has improved, claims management and pre-authorization have improved, the time has reduced markedly, so improving efficiency, but also from a wider system performance perspective, equity has improved because now there's better portability. States like Bihar, UP, Chhattisgarh, Assam, which have less service availability, particularly for some of the specialties like cardiac surgery and the like, transplantation. Now they have the capacity to go to transport their citizens to other states that are better resourced. And so people are getting more service availability. And so that has improved geographic equity and access, reduced out-of-pocket spending as well. We have also seen schemes that were separate schemes. So there was a great deal of fragmentation, particularly at the state level, because PMJ covers the bottom 40%. But now states were also developing their own schemes for the above poverty line segments. But now the governments are using PMJ TMS system largely as an entry point for bringing on board other schemes, initially to harmonize benefits and then merging them for some of them like Kerala, Rajasthan, and so on and so forth, while others have just used it largely to harmonize the knowledge and understanding of what's going on. But again, so you bring the schemes together under one management, but they are still separate, but on the same information platform. The other thing that we are seeing, of course, improve efficiency. We are seeing better transparency, better visibility in the data, so you're able to pick up fraud cases and abuse cases, but has also helped us improve the efficiency, because now with the large, the big data available, we're able to use artificial intelligence to help us, one, pick up fraud cases, but also now we are using it to help us to begin to look at the cost data we are getting as we build up towards the DRG reform. It's also been used as a mechanism for streamlining some quality of care. So we have a well-designed quality metrics with inbuilt indicators that are helping us to follow up on quality, but also we have embedded within the system standard treatment guidelines for all the packages. And those the standard treatment guidelines are a must for the claims processing. And so no claim is cleared unless the services are compliant with the STGs. And so in a sense, we're influencing quality there. We did an impact analysis there, a bit of varied results, but overall seeming to build in a good direction in terms of quality. Lastly, we have used the TMS as an entry point for ICD-11 and ICHI as a mechanism of getting the benefit package in terms of standardizing the nomenclature. India is the first country, to our knowledge at least, that has formally adopted ICD-11 and ICHI, and we're now using that as a basis for what we are calling the WHO grouper. In terms of the unfinished agenda, right now, India is building what we call ABDM, Ayushman Bharat Digital Mission. It is a open federated system that's bringing together stakeholders in the ecosystem, including public and private insurers, public and private providers, hospitals, laboratories, and pharmacies, as well as developers, software developers. And so there is an information exchange platform in which through open protocols, it enables exchange of information across these providers, of course, with the permission of the patient who has a personal health record and must provide consent for access to the data. So what that is doing now, and is our work now with the Insurance Regulatory Authority there, as well as with NHA, is how we can standardize claims processing across the board for public and private. So even private insurers are coming on board so that we have standardized data to give us visibility in service availability, utilization, claims management, even in the private sector that originally wasn't under the purview of the public. I'll stop there for now.
Thank you, Grace, for that synopsis. What I took away is start with what you have and building on the strengths that you have. So the strong IT sector and bringing on those lessons to strengthen health systems, but also addressing fragmentation within the schemes. I wouldn't add more now, but I want to hand over to Martin, who will give us his experience from Argentina as well. Thank you.
Thank you. Good morning to everybody. Thank you, Agnes. I will use a PowerPoint presentation. I am slide dependent man. So I am under treatment to leave it little by little, but not today. So let me see how this works. Okay. Okay. Just a minute, please. Here. Well, the title says, well, linking funding to results for better access and health for the poor. That's the main statement. But I included also a question. And for the whole population as well. Well, this is the story of Programa Sumar and Plan Nacer. It is the same program. We started with Plan Nacer, but then as the program widened its scope, we needed a new name, Programa Sumar. And Argentina has one of the most fragmented health systems in the world. It is composed of three sectors: the public, the social security, and the private sector, that in practice are segmented according to people's incomes. So the Federal Ministry of Health in Argentina holds a stewardship role and has a modest participation in terms of financing. The public sector is highly decentralized. The country is organized in 24 provinces. The largest provinces, like Buenos Aires and Santa Fe, has decentralized primary health care in municipalities, so it is quite devolved. And the public system provides health services for the whole population for free. And it is important to acknowledge that before Programa Sumar, this public system was exclusively funded by input-based budget allocations, something that it is important to distinguish, that before Programa Sumar, no explicit benefit package were defined for the public system, but on the contrary, the social security system and the private insurances must provide an explicit benefit package named Plan Médico Obligatorio. So Programa Sumar aims at reinforcing the public system that covers 38% of the population. And it is important also to know that the social security is organized in 24 provincial social insurances that cover public employees in each province. And we have almost 300 national social insurances. So as you can see, very complex system to transform. So the purpose of the program is to increase access to healthcare services for the people that lack formal health insurance by strengthening the purchasing function through a twofold RBF mechanism. Then I will explain how this twofold RBF mechanism works. The program covers the whole population without formal health insurance, more or less 21 million people in 2020. We followed a gradual expansion. It was an iterative process in terms of services covered, in terms of provinces participating since 2007. All provinces are part of the program, and in terms of populations age groups. But why Programa Sumar? What are the reasons, what are the problems behind the purpose of Programa Sumar? Well, fragmentation and poor coordination mechanisms, no explicit priorities and goals, unclear roles and responsibilities among provinces and municipalities, historical input-based financing schemes, and no data-driven culture. So here we can see the twofold RBF scheme. To improve effective coverage, we need to distinguish between two relationships: the relationship between the federation and the province, and the provinces with their health provider network. In the first relationship, program uses patient payment based on performance. 60% is linked to the enrollment of the target population, plus a health service in the last, a preventive health service in the last year. And the remaining 40% is linked to the achievement of health outputs and outcomes. So we can say that 100% of this per capita payment is linked to service utilization. And then the provinces has to purchase a benefit package using a fee-for-service payment mechanism to incentivize preventive services. Remember that the program places the focus on primary health care, and it can complement this fee-for-service with a per capita payment linked to results. And of course, it is important to sustain and guarantee providers' autonomy in order to close the incentive chain. I would say that this is the most disruptive change that was introduced by Programa Sumar. So in order to internalize incentives. So this is a core rule of the program, and all these rules are concurrently audited by external auditors whose opinion is mandatory for the national government, for the provinces, and for the providers as well. So here we can say something about how important is to well design and well implement intergovernmental transfers or conditional budget transfers. And in terms of well design, I would say that it is critical to achieve a coherence between three main components. The first one is the method to define the size of the transfer pool. The second one is the allocation criteria. And the third one that is critical in order, for example, to ensure providers' autonomy is conditions for the use of funds. And with these levers, with these conditional transfers, we can pursue multiple purposes. For example, the introduction of a common benefit package, the purpose of equalizing funds and creating the right incentives to the effective provision of benefit package, to strengthen the purchasing functions within each ministry, provincial Ministry of Health, to broaden financial autonomy of providers, and for example, to eliminate co-payments. So we carried out 3 impact evaluations that showed a great impact of the programs in terms of neonatal mortality risk reduction, in terms of low birth weight risk reduction, and in terms of the increase of early detection of pregnancy and pregnancy follow-up, among other results. And some institutional achievements I would like to share with you. With less than 1% of the average of provincial health budget, we initiated the agenda for developing the strategic purchasing function in the provinces. Programa Sumar was the main level to develop, to encourage a culture of data digitization in the public system, and that allows us to do real-time monitoring of health service utilization. We empowered public providers. We introduced new tools and management modalities. It played a key role during the pandemic to be the concerted response with the provinces and ensuring sufficient funds. Without any doubt, the Programa Sumar had greater influence along the pandemic and make the system a more resilient one. And finally, it provided the Federation with a stronger influence over the provinces and gradually and silently over the social security system. So how Programa Sumar is silently inspiring the whole system? Well, here you can see a sort of heat map. As you can see, I have a lot of imagination, but we have 4 colors. The red, the strong red one, refers to high influence. The yellow, an increasing influence. Green means incipient influence, and blue, no influence. So, as I said, the program is financing the public system. Of course, it had a great influence over this mechanism, not only to improve access, but also to defragment the public system, because we have many different financing flows, financing programs at the national level, but also at the provincial level. And regarding provincial social insurances that are part of the provinces, it is the same counterpart, because in some provinces, for example, these provincial insurances depend upon the Ministry of Health. Well, we are trying to promote like a virtual integration through the harmonization of benefit packages, through the harmonization of provider payment mechanisms and IT requirements, and very importantly, eliminating co-payments for preventive services. Regarding the national social security, that, as I said, had to guarantee their population a benefit package. Well, since 2019, the Ministry of Health, Programa Sumar, is working with the Superintendency of Health Services in order to create one single benefit package for the whole system. This is very important, not only in terms of the list of services, but more importantly, in terms of defining new rules, new procedures, and new methodologies to prioritize what is included and what is not included in this single package. And all this exercise is done based on Programa Sumar benefit package and experience. During the pandemic, we also harmonized inpatient services in terms of contents and in terms of rates with this Superintendency of Health Services, that is the entity that rules and supervises national social insurances. So I would say, let me make a reflection using this bamboo metaphor. As you may know, the bamboo is one of the highest plants in the world. It can be 138 feet tall. It grows as any other plant in the world because it can grow 4 feet per day. But the most interesting thing is that once you plant the bamboo, it takes years to see a visible growth. You plant the bamboo, you water every day, and it takes at least 3 years to see how the bamboo breaks through the surface. Because during the first years, the bamboo is growing deeply downward. So it reminds me the public sector, this intention to strengthen one scheme, one key scheme where the stewardship role is located. And sometimes you feel that you are not making progress, you are abandoning this comprehensive approach, abandoning the pursuit of UHC, disappointing show, because you are strengthening the scheme and you are not looking for the forest and the whole system. But we can understood this situation as setting the foundations so you can then, setting the pillars, so you can then follow a greater and comprehensive reform across the system. So this is the same message, but from a different angle. Here you can see all the interventions developed by Programa Sumar. It is a package of connected interventions, and you can see how it is influencing, or these interventions are incorporated by each scheme. So to conclude, since 2004, Programa Sumar, these conditional transfers with small budget share has been strengthening the public scheme, but with systemic view that enrich reform discussion and is silently influencing other schemes. Strengthening a scheme and pursuing UHC could be reconcilable goals under certain conditions. Some pending challenges, for example, the Ministry of Health still lacks a long-term financing strategy. I had to acknowledge that perhaps we had a long-term plan from the program, but we need a more comprehensive strategy in terms of financing for the ministry. Provinces have room to further institutionalize their strategic purchasing strategies, and the integration with the social security is incipient. Valuing does not mean institutionalizing. Many provinces, many social security institutions value and believe in the philosophy and the scheme of Programa Sumar, but sometimes it's not a matter of willingness, it's a matter of ability. And it's a matter of vision. So before scaling policy, it could be needed to scale vision and capacity. We need to move forward more distributed leadership and better managers, especially in these countries that are so big and in these countries that are so fragmented. To conclude, I will go back to the bamboo metaphor, saying that sometimes strengthening one scheme doesn't mean adopting a fragmented approach, but the intention to give the reform solid roots and create the necessary conditions to later scale it up. Thanks so much.
Thank you so much, Martin and Grace. You can agree with me that was not a presentation we wanted to cut short, even if we were running over time. So thank you for those reflections. I wish I knew that before I started planting my bamboo fence, which I now realize what you're saying. It's taken forever to grow, but I'm optimistic. But I think that bamboo metaphor, and we love our metaphors as Africans, and realizing that start with the core, the foundation, the governance, and setting that up right so that we can grow more clearly with a strategy, being clear on our goals, but also giving it a good enough framework for whatever we add on or whatever we design in the future. I also am impressed at how little the resources were just 1% of the provincial budget that made a big change. So I know we talk a lot about we don't have enough, we never have enough, but what can we do with what we have? Start small and grow with it. And also just how it's influencing the other parts of the system is just phenomenal. And so something I take away is also the issue of path dependency, and that, you know, we started about 2004. I was very fine in 2004, but 2023, where are we now? And keeping your eye on that vision as we progress and continue to build the system, and keeping your end in mind. So thank you very much again. These were insightful presentations as we go into our group works. I'm hoping that our questions can be taken there. I know we have so many questions, the presenters, but the best part about this is that we want you to engage with them one-on-one. So what we've decided to do is, rather than just open it up to plenary, and not everyone adapts well to a plenary session, we will have 8 group sessions. So we shall have our Francophone group here. So French speakers, we want you right at the front because you're very special. Please come right up here, and you will have Dr. Pierre and Helen facilitating that group. On row 3 at the far end, where my friend Sister Eugenia is, we shall have another group, and that table we're calling table 2, and that will be facilitated by Edwin. And then just here where my other friend is, you can lift your hand, Felegush. We shall have group 3, and that will be led by Joe. And then right at the back, we shall have Grace. If you want to speak with Grace, please meet her there at the far end of the room. And then on this side, we shall have Namala facilitating right at the front. And then where my friend August is, you can raise your hand. We shall have group 6. That's where Gemini will be seated from Tanzania, if you want to speak more to Gemini. In the middle here, on the 5th row, we shall have Ibubeki and Angela, who will be seated there if you want to hear more about Indonesia. And then at the far, who have I left? At the far back, near the booths for the sound team, we shall have Martin. We ask that you distribute yourselves evenly. We do not want to prescribe where you go. Feel free to choose, but if I notice that too many of you are going to one person, I might have to make an executive decision to ask you to move. We also have some virtual attendees, and I'll be facilitating that group. So if you'll take a minute to move to your tables, we have questions here. So think about the discussions we've had so far. Think about the 2 presentations we've just had now, and what are we focusing on? We want to think of what are the key issues that we might be facing, thinking about how we are designing schemes, what are some of the politics behind these schemes, what are the mechanisms that we can use to reduce fragmentation. I know that's a big issue we hear about. Thinking about reaching the vulnerable populations. And then finally, a question on what should we take forward in research. We have 35 minutes, and then Helen will help us with the report out. So please feel free to move. The questions will stay up. Thank you. Hello, can you hear me? Hello, can you hear me? My name is Agnes. I'm one of the facilitators in the room. Okay.
Yes, we can hear you.
You can hear me. Thank you. Thank you for joining the session. And I wanted to check we're all active. Or is it just you and I? Okay, so I hope you've enjoyed the discussion so far and that I'm clear. You can hear me clearly. And if you have any questions, we'd be more than happy to bring them to the larger plenary. But I haven't seen any so far. And so what I wanted to do is to have a chance to just deliberate on the questions, the reflections, the comments that have come up so far, presentations, and give a chance for you to also reflect on your own country experience and speak through how your countries are addressing some of the issues that came up today on fragmentation, on focus on the poor and the most vulnerable, and some of the research questions that should be taken forward. All right, I hope you heard me clearly. I just want to do maybe a quick check. If you'd like to introduce yourself and ask any questions you might have or any reflections you'd like to share from your own countries.
Okay, so I'll go. Muchibwa, hands is up. Yeah, I don't know, maybe I can introduce myself and hand over to him. So I'm
okay. Sure.
Dr. Abdul Jibril Njai. I'm a medical doctor from Sierra Leone. I'm still in Sierra Leone. I've also done training in health systems strengthening and health economics. And I'm currently working for WHO and supporting the Ministry of Health in health financing and human resource for health and health system strengthening. And then through my health economics practice, I've come in contact with IHEA and then also been following and also registered member of IHEA. And yeah, so, and this is my first conference. So, and so far so good. Yeah.
Okay.
Maybe I hand over to.
All right. Thank you. Muchibwa, I saw your hand up.
Hello everyone. I'm Lazarus Mchabaiwa. I'm a health economist with UNAIDS, and I come from Zimbabwe. Yep, that's my introduction. I'm mostly interested in universal healthcare with relation to HIV/AIDS, the response. The challenge that I've seen in a number of African countries is because the response to HIV/AIDS was mostly funded through donors, through foreign funding, and as the funding landscape is changing, I'm more interested maybe in learning how other countries are incorporating HIV/AIDS into their health financing, and also with particular attention to key populations and so on. Over.
Okay. Thank you, Muchibwa. I had a similar question yesterday in a session I was attending. So it's interesting that you brought that up here. So, and I think it is a relevant question. So I don't know if there's anyone else who wants to introduce themselves before we start. We have just about 20 minutes though. So feel free to unmute yourself and just introduce yourself. So I also want to say, Njai, I'm here with Joe Katzin, and he saw you online and told me to pass his greetings. He's very pleased you could make it today.
Who?
Joe Katzin.
Oh.
Yeah.
Yeah.
Okay.
All
right. Yeah, we have a few WHO colleagues here. Okay. So I will pass them on. So maybe you already set us up, Chabiwa, when you asked about people living with HIV and the inclusion. And maybe I can reflect back. We had a health financing dialogue in Kenya about a week ago, and that particular question did come up, and how we are classifying the most vulnerable and the poor, and could certain disease conditions be considered as vulnerable and be included as potential candidates for government subsidy in the inclusion in health insurance programs. In Kenya, we have our National Hospital Insurance Fund, which was recently rebranded to NHIF, and National Health Insurance Fund, and they have included HIV treatment as part of the benefit package. But in reality, because there's so much funding coming through Global Fund and PEPFAR, many of the patients are getting them through the subsidized services. So the question we have is, can NHIF really afford to provide ART for the millions of people who are, at least 1 million people who are on ART currently, even if they're included in NHIF? So there are issues of sustainability as well. And could there be other mechanisms that can be used for certain population groups, or for funding their specific treatment requirements? So it's very clear you can project and plan for ART for a year, for example. Could there be a fund that is dedicated to purchase those commodities for them? So that's not part of the NHIF reimbursement to be made, and so it will be more of the diagnostics and clinical care, but the treatment part of it is catered elsewhere. So just to say, I think it's a discussion that will come more and more. But we also heard from Edwin earlier that insurance coverage in many African countries is still very low. So I guess the question is, what would be the mechanism for inclusion? Are these going to be subsidized? Are we expecting them to contribute? And then what does that mean for financial sustainability of these insurance schemes that really have very low coverage? So I'll stop there, maybe just to ask if you have any reflections from your own experience or from Zimbabwe, how you're thinking of tackling this question.
Okay, thank you so much. Yes, indeed, a few reflections. What is happening is, I think different countries are struggling at the moment with debt and so on to finance their own healthcare. However, these, as an economist, I look at them as investments. We've made significant progress in the area of HIV/AIDS, but if the countries maybe do not commit to funding, especially through the benefit packages, then we are simply saying we cannot sustain the progress we have made in HIV/AIDS over the past decade or so. I could say I was really excited when I heard the issue to say it's not one size fits all. Each country has to start from somewhere. And I think Kenya did a very good example. They are starting from somewhere and they have their strategy which they are going to move forward with. Maybe the discussions will go on. For us to say the governments can finance, can subsidize, I think that will be the way forward due to the high level of informality in these economies. Kenya, Zimbabwe, a lot of people are employed in the informal sector. So one way would be for the government maybe to find ways to increase, maybe through additional taxes or investment in e-government, what we had from the Indian experience. I think we also had something similar on the first day regarding Taiwan and Denmark, that investments in e-government can be springboard maybe to ensure efficient collection of tax revenue. That can then be used maybe for the subsidies that we are talking about and so on. In Zimbabwe, I was part of a team. I led a team, in fact, that tried to look at community-based health financing in rural areas. This is not specific to HIV, but just to say that in order to help the government at the moment when they are not, when they have got a number of priorities, maybe the communities could start, could start making contributions. Of course, the contributions from our research, they were not sufficient, and this is even covered in vast literature, that communities would need some subsidy, would need someone to aid up on what they can raise through community-based health insurance schemes. So from my experience, we have ways maybe, especially e-government, that can be used to raise more revenue, as well as communities may be coming in. They cannot raise what the voluntary health insurance schemes that are private, that they are demanding in terms of premiums, but they can start their own community-based health insurance schemes, and we start there. Over.
Okay.
Yeah, I don't know if I might come in.
Yes, please.
Yes, so from also trying to go with the group work directives. So from Sierra Leone, we have been having discussion to have a contributory scheme for a couple of years now. And it has been more political than technical. The fact that firstly, at the political scale, it was started by another party which is out of governance now. And when the first party came, this current party came, they initially we're not seeing the need for it, but when they keep having pressure for increased self-financing, then they prioritize the scheme, and they've tried to do some more studies. They've even do some exploration, going to other countries to just learn and transfer experience. But when it's, they've passed a bill in Parliament to be able to enact the contributory scheme, but when it comes to putting the money, the initial investment fund, there were a lot of drawbacks, and then shy away, donors pulled back and started asking certain questions which were technically not answered. And so what happened is that the pressure was now with the president and the vice president to act. And then the vice president was like, okay, but I don't see why this is a wise investment. What's the investment case? And so the Minister of Health has to pull back. And initially, there was also politics between the Ministry of Health and the Ministry of Labor and Social Security, because it also seems as if the initial campaign to set it up came from the Social Security, which wanted to just do a strict social insurance, which the Ministry of Health and as WHO advice is against, because you then only be protecting the workers and the rest of the population is out. So eventually the Ministry of Health won that argument, and so it came under the Ministry of Health, and Social Security pulled back and Labor a bit. So the money has not come forth. Of course, donors are not interested, so they're staying away from it. But obviously with the high of what's going on, and so the head of the insurance team, they tried to get sort of an investment case. I think one or two consultants, one from I think Kenya, Zamara, or they came and did an investment case, which was presented to the vice president, and that was earlier this year. So, and now we've also had a round of elections, and we hopefully, the way things are going, we might be going into these dynamics even next year. So, coming out to some of the things you've said about like catering for certain populations. Yes, in Sierra Leone, we also have a number of free schemes for certain diseases, HIV, TB, malaria. Malaria is a highly endemic area as well, and malaria also has a couple of benefit package. that is free for the entire population. And I quite share the concerns that you've done. It's the question of sustainability is huge because a lot of the funding for this is coming from outside, and there are currently no subsidies, even though people go out for, I think Gavi, they've put some form of co-financing element, but sometimes they have to, for the government to come up with that part of their own commitments, they struggle to do it, but although eventually they meet those commitments. But also because for the past decade, we recorded very high maternal mortality and child and infant mortality. I mean, maybe you could have heard of them, some of the highest in the world. So I think in 2009-10, the government introduced a free scheme also for pregnant women and children under 5. And a huge part of the package for that scheme is funded by, I think, the UK and some other donors. And the pressure has been for the government to take over the initial plans where they after 5 years, 10 years for them to come in. And they've not been able to come in. So what we've seen is that the package keep going down. So for example, we take the drugs, there were over 100 drugs that were listed as essential for maternal and child health. But instead of now buying 100 of those, they've been increasing to 60s. And now I think they're only buying like 40 of those essential drugs. And the government is really not matching up or coming up, and obviously it's a small fiscal space in Sierra Leone. There's a lot of economic and the macroeconomic environment is also quite challenging. But just as you were saying, there's this challenge of sustainability and this fee scheme, sometimes how countries can go on. And it's an interesting discourse that we've also been exploring as to how we could go with those, because at the moment the debate is not going there in the finance and in the leadership or political lens as to for them to take. And if not, these populations will also suffer in the future if we are not careful. I think those are my initial reflections for now. So over to you.
Thank you. I want to check if anyone else would like to reflect on this question on how we're addressing the poor and most vulnerable. But just saying, I really appreciated what you both shared. And I think a big issue is sustainability. So, Jai, when you say that, for example, in Sierra Leone, there are these free care programs. And in many countries, there are free care programs. So the reality is that they are largely donor funded. And in many cases, we're not seeing the commitment of government to match or to meet some of these most basic of obligations to the most vulnerable. So yes, we have this, whether it was exempted services that Gemini talked about in Tanzania, the e-gratuite, which is in Burkina Faso, or in your case in Sierra Leone, that if government is not able to match up, then it means that we do lose coverage, and for the most vulnerable who are going to be hurt the most. And rolling back, and I think that's what Muchamba, you were saying, that we might be rolling back our gains that have been made, whether it's in coverage of ART, whether it's improvement in maternal and child health indicators, if we're not able to continue to sustain these services. And maybe that's the question I have for you. You already mentioned or alluded to politics behind this, and that politics do change. And when they do, sometimes you have to roll back. But maybe any examples you'd like to share about how we're able to also address the politics behind these, whether it's keeping priority on health services or raising enough resources for health. Any reflections you'd like to share? From your countries and also others where you might have experience. I'd welcome that.
I think for us, the politics, the way we've been able to manage it is because I think there was a committee that was formed by the vice president, which he chairs. It's called the UHC Steering Committee. And in this committee, he was able to pull together Ministry of Labor and Ministry of Finance, Ministry of Health, and the Labor also comprising of the National Social Security Trust Fund, and be able to get them on the table to understand and settle differences between the Ministry of Health and the Ministry of Labor. And then I've been able to have a team of people also in the health insurance working to operationalize the health insurance. Whilst the politics is keen on interest and being represented, like I said, when it comes to the money or initial investments, then everybody shy away because I think given the assessment that we done earlier this year about the initial investments, so we're talking about $50 million to get going, and that's a lot of money in a lot of ways. And again, this has been something which the country has not put forward to say, okay, we're going to provide this, or maybe gradually or start, because I think they did several models of how to start and upscale, or what would be the enrollment over those timelines. But yeah, so the discussion is but the part for me that has also been interesting is the fact that I think this is also maybe political in a way, that the donor lens when it comes to contributing and non-contributing scheme in Africa or low middle income country is that we've seen donor obviously not showing interest because of maybe what's the research and scientific evidence is saying currently about the schemes, the current schemes, maybe in Ghana and Kenya. Myself, when I was doing my master's in health systems and in my thesis, I did it on health insurance in Africa, and I was looking at Ghana, Rwanda, Kenya, and Tanzania. And of course, one of the things that stood out was the coverage was so low in all of this country. I think at the time it's Ghana that had the highest, which was 35, and since then it has also been stagnated at that level. And it is the same around, I think Kenya one has gone a bit, maybe from 19 to 20, around 20 something, but even Tanzania at the time was around 11%. And of course, Rwanda, because of their own model, they had a higher one, which was I think around 70 something. But there's that stagnation, and certain groups, like we're saying, the vulnerables or people are still left out. So, but what's the way forward for me with donor involvement? Because the stagnation is not there because the schemes are not, I wouldn't say they're not working, because there are challenges which are contextual. And as people trying to solve problems, those would be the things we're looking for, but rather than just playing the, I don't know if I should call it technical or donor politics to just say, no, health insurance will work in Africa or contributory schemes won't work in Africa. But what's the next step to solve those challenges, to really be able to maybe fund more research in the region and know that what are these bottlenecks, what are these things? Because it's a pattern, but yes, that shows that there are certain things that are really in the progress of contributory schemes, in the region. So, and as I learned also doing my system courses, at the end of the day, even the tax that we promote in the public funds and through tax, they're also contributing in a way. And they also are not doing well. So we forget about insurance. Okay, let's don't form insurance. But then whether it's going to be sin tax, whether it's going to be the general income tax and all these VAT and things, there's still a challenge in the region. So is it that we need to focus on more digitalization of revenue collections and being able to also digitalize expenditures and this kind of things in the region? Are these the issues? And how can be donor interest? But at the moment, the whole donor way of, I would still think it's politics of dealing with, there's not much support from that side of funding of donor, which is also contributing ends to this stagnation, from my own view, and from my experience in Sierra Leone, to this whole effort of solving revenue mobilization in Africa. Over.
Okay. Yeah, thanks, Njai, for that comment. Maybe I just want to say that we're about to wrap up. So I want to ask if Njai wanted to add anything before we close. I don't want to take his time.
Okay, thank you. So I heard what my colleague just said, that governments are under a lot of pressure. But what I've learned, I think, from the Zimbabwean case is if we have an earmarked tax, maybe because it has worked for HIV, it might be insufficient, but there is an earmarked tax for HIV funding in Zimbabwe. And if we're going to think about maybe a package, for example, under UHC, then maybe if it is driven through an earmarked tax, that would work. Because the government at the moment, they've got many priorities that are competing. And as long as that money is not ring-fenced, it will not find its way into UHC, especially at the moment where people are afraid that once they commit to say we're including HIV under UHC, for example, then the donors maybe would withdraw. So I'm still an advocate for public financing of UHC in general. Thank you.
Okay. All right. No, you're right. And maybe to wrap up here, because I'm also getting pressure to do so, is that, I don't think we're saying one way is bad, one way is good, but it's also what works best, looking at our context. So, health insurance has worked in many countries in Asia, but here even at home in Africa, Rwanda, and Ghana have shown, decent coverage. Although even, for Ghana, just about 60% coverage. So, still not quite there yet. But I think the question is more of, these health insurance schemes as a purchaser to define benefits, to purchase services. Maybe that's where they do well, but we shouldn't expect that the revenue collection through contributory means, collecting premiums, is necessarily going to work for our context. And so, I've had what you both said about, contributory mechanisms, maybe as people paying contributions to get coverage, maybe we need to think through how we can use other means to raise resources for these schemes or for coverage of the most poor, the vulnerable informal sector, as opposed to expecting them to contribute, because even these mechanisms to identify them, to collect, are also quite expensive as well. So, I think it's being pragmatic and manage our expectations, and governments really beginning to realize that there will need to be some way to raise revenue through either tax or non-tax revenue. And probably that's a more efficient way of trying to get resources for the health sector than trying to imagine these health insurance companies will now collect premium solutions. But, it's really context specific. So as I said, maybe we had Rwandese on the call, they may not agree they've managed to make this work, but, regardless, there is quite a bit of subsidy that goes in. We saw in Indonesia, 60% of those covered are actually through subsidy. And, they have over 284 million people covered. In India, the same, the PMJ system that was shared earlier by Grace, that is all subsidy for a small package of hospital benefits. So what can we learn from these experiences, even as we design our own? So as I said, we're wrapping up here. I just want to say thank you very much for your reflections and contributions. I will take them back to the room, and I hope you continue to stay on for the session. Thank you so much for making time. I know it's a Sunday morning, may not have been the most convenient time, but we do appreciate your answers. Thank you very much. And please stay on for our wrap up. In the next 40 minutes, we'll be done. Right. Thank you.
Thank you too.
Okay, thank you, Ajay. Thank you, Muchebawa. So we'll get them all.
if they do work.
All right. Hello, everyone. I know you're having very exciting discussions, which will continue at lunch. For now, I'd ask that we regroup. You don't need to physically move. You can stay there for the next 30 to 40 minutes as we wrap up, okay? So I'll hand off to Helen.
Okay, thanks a lot, Agnes. So let's get started with the wrap up. I see that there is still a lot of conversations going on, but we need to come back to the plenary. There's some echo from there. There is some echo. I think the sound is on your laptop. Yeah. On my laptop? I don't know. Yeah. So you need to.
Seems like the same time.
Okay, so we have. Can we just, yeah, show us that. So we had 8 groups. What I would like to suggest, yeah, have a seat, Joe, please. What I would like to suggest is that we don't do the reporting for each and every group for the 4 questions. I would like to pick up a few questions and then give the floor to some of the groups to highlight a few key messages, okay? Have a seat. Thank you. So let's get started with the Francophone group. We have a rapporteur as Dr. Joël. So Joël, it would be great to hear from you on the first 2 questions. Could you tell us what were the new schemes that were introduced recently in Burkina Faso? I think you've discussed the case of Burkina Faso. So what are the new schemes that were recently introduced? And also, if you could share with us some lessons from how the countries has actually managed to reduce fragmentation in process. Over to you, Joël.
Thank you very much. I will speak in French. So I ask you to put your... Ok, donc je vais parler de la politique de gratuité des soins dont Pierre a parlé en fait ce matin. Et c'est une politique dans laquelle I will wait for a moment for people to put their ask. Okay, it's fine, so I can start. Donc, je parlais de la politique de gratuité des soins dont Pierre a parlé ce matin. Et essentiellement, et c'est une politique dans laquelle le panier de soins a été progressivement élargi. Donc, on a d'abord commencé avec la gratuité pour les femmes et les enfants de moins de 5 ans. Donc, et pour les enfants, c'était essentiellement des soins curatifs et des maladies aiguës. Voilà, mais les maladies chroniques étaient exclues, donc, sauf les complications donc, qui survenaient au cours d'une maladie chronique. Voilà, et pour les femmes, donc, il y avait la détection du cancer du col de l'utérus, donc le diagnostic du cancer du sein à travers la palpation, et également tout ce qui a trait à l'accouchement, voilà, et aux soins prénataux. Donc, il y avait également les fistules obstétricales. Et la politique de gratuité a commencé en 2016 et 3 ans plus tard, en 2019, le panier de soins a été élargi à la planification familiale. Voilà. Et il faut dire que ce n'était pas uniquement focalisé sur les femmes parce qu'il y avait également les les condoms masculins dans le panier de soins. Et progressivement, ce panier de soins a continué à être élargi. Et récemment, on a inclus dans le panier de soins les soins de radiothérapie et aussi la coronarographie. Donc, qui sont des techniques qui sont mises en œuvre depuis pas longtemps. Voilà. Mais comme c'est des soins très, très coûteux pour les personnes qui souffrent de cancer, donc ça a été introduit et on envisage d'introduire les soins pour les personnes âgées. Donc, ce n'est pas encore effectif, mais la réflexion est très, très avancée. Et il y a les soins également pour les PV-VIH, les personnes vivant avec le VIH. Donc, il y a une autre politique dont les réflexions ont commencé depuis 2008 et la loi a été adoptée en 2015. Donc, il s'agit de l'assurance maladie universelle. Mais ça fait depuis 8 ans, on est toujours au stade de formulation de la politique. Donc, elle n'est pas vraiment mise en œuvre sur le terrain. Donc, ça, c'était par rapport à la première question. Voilà. Maintenant, par rapport à la deuxième question, quels sont les mécanismes qui ont été mis en place donc, pour éviter la fragmentation? Donc, il faut dire qu'au Burkina, dans le cadre de la politique de gratuité, il y a eu un gros débat donc, sur comment améliorer la fonction d'achat. Donc, il y avait un peu deux courants. Il y avait le financement basé sur la performance, donc qui était mis en œuvre au Burkina depuis 2014 et son extension en 2018. Donc, on ne savait pas s'il fallait reproduire l'ancien schéma de financement basé sur la performance ou bien comment mettre en œuvre les mécanismes d'achat stratégique. Donc, il y a eu une sorte de clivage entre les techniciens du ministère de la Santé et sur comment opérationnaliser ce concept d'achat stratégique. Voilà. Et avec l'aide de Spark, donc il y a eu une sorte de conciliation, si je peux ainsi dire, et les différents acteurs ont pu avoir une compréhension assez harmonisée de ce que c'est que l'achat stratégique. Voilà. Et à partir de là, donc les choses ont commencé à bouger sur le terrain. Sinon, on allait se retrouver avec deux mécanismes. Donc, un mécanisme PBF financé par la Banque mondiale et un mécanisme, je peux dire, d'achat stratégique, donc promu par le ministère de la Santé. Donc, en réussissant à concilier les différents points de vue, donc on a évité une sorte de fragmentation au niveau du système de santé. Il y a également cette réflexion en cours, je termine par là, donc pour voir est-ce que la fonction d'achat et de la gratuité doit être transférée à la caisse qui n'est pas encore fonctionnelle. Voilà, mais ceci reste vraiment en discussion parce qu'il y a beaucoup d'avantages et d'inconvénients et il faudrait très bien réfléchir sur la question avant de s'y engager, donc pour éviter plus tard des regrets. Voilà, si je peux dire ainsi. Merci.
Okay, thanks a lot. So 2 new mechanisms, new in the sense that mechanisms that were introduced in the past 10 to 20 years. The first one was a compensation mechanism after the removing of user fees, okay? And I think here the innovation was the fact that there was a subsidy from the government that was used to compensate facilities, right? So in that sense, it's a governmental scheme. And then the second policy or initiative that was taken is related to the introduction of a social health insurance fund, but is still under discussion and under definition, if I understand correctly. I know that Pierre, you wanted to add an additional insight to the process, so I'll give you the floor and then we move to the next group.
Oui, c'est vrai que quand j'expliquais ce matin, pour ce qui concerne le fait que le gouvernement alloue en gros plus de 50 millions de dollars chaque année pour soigner gratuitement. En réalité, ça s'est fait avec des dérogations spécifiques au niveau des finances publiques pour que nous puissions y arriver à ce niveau. Et il y a 3 points spécifiques avec lesquels nous avons discuté avec le ministère des Finances pour que nous puissions effectivement atteindre les résultats. Le premier point, c'est que les ressources sont allouées directement aux formations sanitaires et ces ressources allouées directement sont accessibles à tout le monde, à tous les acteurs. C'est des fichiers qu'on transfère et chacun sait combien il doit recevoir. Le deuxième point qui est très capital a concerné surtout des avances. Vous savez que les ressources de l'État, c'est un service, on paye après service rendu. Mais au Burkina Faso, nous avons opté pour que l'argent arrive dans les centres de santé avant qu'ils ne puissent réaliser les prestations. Donc, c'est des mécanismes de prépositionnement qui ont fait qu'on a pu avoir beaucoup plus la confiance des acteurs pour pouvoir rendre disponibles les produits. Et dans ce mécanisme, on a gardé l'avantage du tiers payant, c'est-à-dire que ce n'est pas qu'on prend l'argent, acheter des intrants, à les déposer, mais les formations sanitaires font les prestations et que c'est l'État qui paye à la place du patient. Et le troisième point de dérogation spécifique des finances publiques, ça concernait les pièces justificatives. Donc, pour ceux qui savent, quand vous dépensez de l'argent du public, il faut toujours une pièce justificative. Et ça, nous avons négocié pour que toutes les pièces justificatives restent au niveau des centres de santé, de sorte à ce que on puisse aller vérifier, voir l'effectivité des soins. Donc, ça fait que, en combinant ces trois, nous avons pu garantir beaucoup plus la confiance au niveau du ministère des Finances qui continue chaque année à allouer davantage des ressources financières. Et l'autre aspect pour terminer, il faut un mécanisme de contrôle robuste. Et au Burkina, nous avons externalisé pour que le contrôle ne soit pas réalisé par le ministère de la Santé, mais beaucoup plus par les organisations de la société civile qui établissent les niveaux de fraude, les niveaux de surfacturation qui sont pris en compte dans le dispositif. Et comme je l'ai dit ce matin, d'ici peu de temps, d'ici la fin de l'année, nous allons migrer vers un dispositif plus intelligent en utilisant les données de plusieurs bases pour pouvoir créer l'intelligence artificielle des données numériques pour être encore plus efficient dans l'achat stratégique. Merci beaucoup.
Okay, thanks a lot, Pierre. I think this is really an important dimension that you are bringing to the discussion this morning. It means that in the context of Burkina Faso, you were able to use the existing governmental systems to transfer public funding to the facilities. You were able to shift to ex post control, and you were able to pay on the basis of outputs. And I think these are the features that are typically associated with health insurance funds or with a separate off-budget purchasing entity. In Burkina Faso, and I know it's not unique to Burkina Faso, you have proven that those features, those functions are also feasible within other modes, so within existing governmental systems. So I think you're bringing a very important dimension and perspective to the discussion this morning. The question being, are there some alternatives to insurance-based systems in contexts where we do know that labor-based contributions are unlikely to come in. So we know that these systems do have some important limitations to feed the context of low and middle income countries. So thanks a lot for this point. Sorry for being long, but I thought it was really an important dimension to bring in. Let's move to another group. Is there a particular scheme that you would like to flag in one of the other countries where you think that is really an important scheme to bring into the discussion? Group from Edwin, Ibubeki, something that has not been covered, something that is not a compensation from user fee removal, something is maybe not similar to what Burkina Faso has done on introducing social health insurance, something that is that we have not yet covered. Edwin, do you want to come in? Do you have a rapporteur? Yeah, please.
Thank you. I guess we've managed to cover some of the questions out there. But I guess the issues we discussed out here are pretty much similar with what it was discussed. We've put spotlight on Ethiopia, Ghanaian case, Nigeria, and South African experience. Okay. In Ethiopia, we are launching social health insurance anytime in the coming few months. It was anticipated to be launched in the past, but due to some political issues, it has been pushed, and we are anticipating it to be launched in the coming few months. The other new schemes that we discussed about were the Ghanaian National Health Insurance, South African National Health Insurance Scheme, and Nigerian experience, but most of them have been active throughout. We've also discussed the political dynamics behind those schemes. In Ethiopian context, launching social health insurance has been politically sensitive issue with regards to the contribution amount to be covered and the government subsidy for the insurance scheme. With respect to Ghana, it has been a campaign promised by parties to have a national health insurance, and I think that has succeeded, but somehow the issues with the provider payment modality has been an issue, particularly in Ashanti region, and we've also discussed that. In South Africa, the political challenges are mainly stemming from the political economy from the private sector, and with the provinces, the issue with fund transfer, and also the benefits package and accreditation not being fully properly defined has been identified as an issue. Mechanisms
to reduce fragmentation in.
Yeah. So regarding the mechanism to introduce fragmentation, we've discussed about the Ethiopian endeavors to introduce pooling directives, and we're encouraging to have a regional level pool and ultimately envision for a national pool. Similarly, the other countries which we've covered, have pretty much the same experience with that. And focusing on the poor and vulnerable in Ethiopian context, there is a 25% subsidy from the government targeting to those who cannot afford to pay the premium, and this has been discussed in our sense. Similarly, in Nigerian context, the availability.
There's some political backup for this decision?
Yes. So there has been a strong discussion in the Ethiopian Health Insurance Service. The Ethiopian Health Minister has, I think it's fair to say, convinced the federal government to subsidize part of the payment or the contribution to the fragmented schemes. So this is one positive take from our side. Maybe on the similar experience from Nigeria is the vulnerability fund they've allocated. Of course, we haven't covered that very well, but this has been some of the issues that our group discussed. But if there is anything missing, maybe you can add.
From the group? Oh. Okay, please go ahead. Yeah. From Nigeria, maybe?
Yeah, from Nigeria. Thank you so much. Because I actually had my brother over there trying to talk about the Nigerian issue. Actually, something quite instrumental we have done in Nigeria at this point is the fact that health insurance before now had always been voluntary in terms of legislative framework. There was a National Health Insurance Scheme Law 2004, which set up the National Health Insurance Scheme. And then close to about 2014, then there's this reform to decentralize, because at that point, we realized that less than 5% of the population was covered by health insurance, largely individuals in the formal public sector employment, the military, paramilitary, and what have you. Now, to solve that issue, there was the National Health Act 2014, which encouraged states to begin to have subnational health insurance schemes. All of the laws setting up these subnational health insurance schemes stipulates that these schemes shall be made mandatory. However, the national law says health insurance is voluntary. And in Nigeria, the constitution is clear. When you have subnational government laws, ultra vires to the provision of the federal laws will take precedence. So you had the 36 state laws saying health insurance was mandatory. However, at the federal level, it said health insurance was voluntary. So you couldn't enforce the mandatory provision, even at your state level. But then there's a watershed that has happened in the year 2022, just last year, about May, specifically on May 19th last year, we had a watershed event where the National Health Insurance Scheme Law was repealed, and we now have a National Health Insurance Authority Act 2022, which now makes health insurance mandatory for everybody who resides in every legal resident of Nigeria. That's a new thing, but what it has done is to also provide for a vulnerable group fund that will take care of the vulnerable Nigerians. Before this time, we had the Basic Healthcare Provision Fund, which is funded by 1% the consolidated revenue of the federal government, currently taking care of about 6 million Nigerians. But when we look at the fact that there's a deficit, we have about 83 million estimated vulnerable Nigerians. How do we take care of them? Then the Vulnerable Group Fund is provided for now by the 2022 National Health Insurance Authority Act to fund for these guys. At this point, there is a removal of petrol subsidy in Nigeria, which is a big issue at the moment. So there will be some savings. And then I've just, like I shared in the group, been added to a national steering committee that should look at how this will truly be implemented at the various state levels. Because that National Health Insurance Authority Act says every Nigerian must have health insurance, irrespective of where you reside, irrespective of who you work for, a basic package, universal health coverage plan that you must have. Then if you are not satisfied with it, then you go for complementary health insurance to be provided for by private health insurance organizations and HMOs and what have you. So that's where we are at this point, looking at all of this.
Yeah, thanks a lot. So an important shift from voluntary mechanism to a compulsory approach through the adjustment of the regulatory framework, if I understood correctly. Very interesting. Okay, I'm just looking at the clock. I would like maybe to turn to one of the last questions that we had, this focus on the poor and the vulnerable. I know that in some of your countries, there was no specific mechanism that were introduced specifically for the poor or the vulnerable. But I know also that some approaches have been conducive to actually benefiting more the poor and the vulnerable. And it was something that we discussed in the Francophone group. The user fee removal was not necessarily targeted for the most vulnerable parts of the population. But when a study by Thinkwell was done earlier this year, it was demonstrated that actually, even though the most vulnerable were not specifically targeted in the design of the policy, it's actually the poorest that have benefited more from the policy, right, than the rest of the population. So my point here is that probably targeting is also possible without explicit targeting. Okay, any similar or complementary insights, examples from your group? Maybe you wanted, and Grace? Yeah, please go ahead, and then Grace, and I think we need to close.
Sure, thank you. I would just like to share from the group on Indonesia that had very good similarities with Cambodia, although with not matching political will. So what we are saying around targeting for the poor, we have seen both contributory and non-contributory schemes at play, where the contributory are targeting the formal sector and the non-contributory are targeting the poor, but also the definition of the poor is uneven in these countries, but also with a very, what they've called a very sharp knife, like the cutoff is very sharp, that 1 year you're poor, the next year you're not, and you're not benefiting and you're left without cover. So what we're seeing here is where they're giving subsidies, they are using essential medicine lists that are outdated, but also limited budgets and limiting them to public service and not the private sector or a mix of those. And we are seeing people are left with no option to access care because where they are being pushed, there's no medicines or care, and they're in between. So we came up with something that we are calling the missing middle or the near poor, that are oftentimes left without care, where we have the government subsidizing or paying for the civil servants, then the formal sector employees are paying for themselves, and then we have people who are hanging in balance. So for Cambodia, what we are seeing is a revision in the law to extend the government payments or the government contribution to the near poor. However, they still have challenges of targeting and defining who even the near poor are.
Okay, excellent, excellent, great. Anything else?
Thank you. I want to reflect largely on A and D in terms of requests that came from the group for way forward in terms of guidance, I think, and also support. We had a mix of 2 countries that are more established with their health insurance reforms, and then 2 that we are looking to start a mix of contributory and non-contributory. The similarity in both those countries was political challenges in terms of the legitimacy of the governments or the players, where to place the authority in terms of the management of the scheme, who runs the scheme, the collection of the revenue and things like that. Political impediments to the reform that have stalled the reform process, and we saw that reflection earlier in the Kenya example that Edwin presented. And so the request was more in terms of guidance, really, a synthesis of evidence across similar situations where countries began off in a fairly similar place where the politics was not favorable for engendering trust and legitimacy and in the system, and all how then countries can move from that, what design elements can be put in, what are the stakeholder engagement processes. So I think that was a specific area of research going forward that needs to be addressed. The other one was around guaranteeing medicines availability within the context of health insurance reform, whereby the bottleneck is not necessarily autonomy issues or what it's the bottleneck is higher up in terms of claims processing and payments. What should be done, especially in a country where it seems to be the steady state, that it's like a gridlock that it has failed to be unlocked. What kind of innovative approaches can be looked into by the research community to guide countries in unlocking those? The rest, I think, shall be handed over.
No, excellent points. Yeah, thanks. But I'm looking at the organizers. It seems that we need to close here. I wish we really had more time. It seems that the discussions in the groups were very stimulating. Let's continue over lunch. And I think we have 2 more activities. One is my closing remarks, and then Joe's closing of the closing. Okay? Okay. Yeah, let's do that together. I just have one slide. The reason why I've put this slide in English is because I've been asked to speak in French to keep and maintain the bilingual aspect of this session. So I just give you 1 minute to put your headphones, and I'll provide some thoughts in French. Donc la première chose en fait que je voudrais noter avec vous et qui renvoie vraiment à la présentation de Joe ce matin, c'est sur la confusion des termes. J'ai l'impression, et j'ai l'impression que ce n'est pas qu'une impression de ma part, que encore aujourd'hui, quand on entend UHC, Universal Health Coverage, couverture santé universelle, dans les pays, on comprend couverture assurance universelle. Je laisse du temps pour la traduction. Donc, il y a encore cette confusion qui existe. Il y a à peu près 15 ans, l'OMS avait bien défini la couverture santé universelle avec 2 dimensions. Joe l'a rappelé ce matin, l'accès et la protection financière. Mais cette année encore, quand je suis allée en Côte d'Ivoire, on a eu un atelier en février 2023. Et quand j'ai fait une présentation pour dire oui, la couverture santé universelle, ce n'était pas l'assurance maladie. Là, tout le monde m'a regardé, m'a dit « Ah bon? Ah non, mais nous, on n'avait pas compris ça. Nous, on croyait qu'on avait appliqué toutes les recommandations de l'OMS et de Joe. Ah, maintenant que vous nous dites que peut-être il y a des autres moyens, que la couverture santé universelle, ça ne veut pas dire l'assurance maladie, ok, bah alors on va voir, on va reconsidérer. Donc je crois en fait qu'on a tous une responsabilité dans cette confusion. Ce n'est pas simplement l'OMS, ce n'est pas simplement les gens dans les pays. Je crois qu'en tant que communauté des économistes de la santé, on doit maintenant faire tous ensemble à nouveau ce travail d'explication pour dire non, CSU, ce n'est pas l'assurance maladie. Okay, CSU, c'est un objectif. Il y a des moyens pour arriver, pour progresser vers cette couverture universelle. Et l'assurance maladie, c'est une possibilité, mais il y en a d'autres. Je suis désolée, je pense qu'ici, vous êtes tous convaincus. Mais vraiment, dans les pays, c'est un débat qui est encore très chaud et je crois qu'on doit continuer ce travail de pédagogie et d'explication. Le deuxième point que je voulais soulever, c'est que, en vous entendant ce matin, j'ai l'impression que cette distinction entre contributif et non contributif, je me demande si c'est vraiment une distinction qui est aujourd'hui la plus pertinente pour les pays à revenus faibles et intermédiaires. J'ai l'impression que cette distinction, elle est encore inspirée en fait du raisonnement de l'assurance maladie. Parce que finalement, ce qu'on sous-entend, c'est que, en gros, contributif, c'est l'assurance et non contributif, c'est le budget. Et je pense que voir les choses par cette catégorisation, c'est très dangereux. Parce que de mon point de vue, les mécanismes qui passent sur le budget, qui passent à travers le budget, et je crois qu'Edwin nous l'a dit pour le Kenya et d'autres, sont aussi des mécanismes contributifs. Ils sont contributifs via des taxes, via un panier de taxes. Et je crois que notre responsabilité ici est la suivante. Si on donne l'impression que ces mécanismes-là, eh bien, personne n'y contribue, ils sont gratuits, je crois qu'on donne vraiment une mauvaise impression. On donne l'impression qu'effectivement, ce sont des mécanismes qui ont peut-être moins de valeur, qui sont non contributifs. Et je crois qu'on porte une responsabilité ici en tant que technicien. Et donc, à mon sens, il faut dépasser cette distinction entre contributif et non contributif d'un point de vue de la mobilisation des ressources. À mon sens, si on veut utiliser cette distinction, c'est du point de vue du patient. Qu'est-ce qu'il en est au moment de l'utilisation des services? Parfois, il y a des copaiements, parfois, il n'y en a pas. Et c'est, je pense, de cette façon-là qu'il faut voir la nouvelle catégorisation des mécanismes. Le troisième point que je voudrais aborder avec vous est un petit peu sensible, mais j'ai l'impression que dans le contexte de cette conférence qui promeut donc la diversité en matière d'économie de la santé, c'est le lieu pour évoquer ce point-là avec vous. Ce point-là est le suivant. Dans les différents appuis techniques qu'on fait à l'OMS avec les pays, on a l'impression, et vous me direz si je me trompe, qu'il y a cette idée qu'effectivement, il y a une sorte de transfert des idées qui ont été introduites dans certains pays européens, donc des idées comme l'assurance maladie, et donc il y a une sorte de transfert entre ces idées-là, ces initiatives, et les pays du Sud, entre guillemets. Et à mon sens, ce transfert politique, c'est quelque chose qui est assez conceptualisé dans la science politique, donc ce transfert de politique, pour moi, en tant que Française, elle fait partie du même processus que la colonisation. Et je crois qu'aujourd'hui, on porte une responsabilité qui est de deux ordres. En tant qu'économiste de la santé, je crois qu'on doit travailler d'un côté avec les partenaires et de l'autre avec les gouvernements. Je m'explique. Avec les partenaires, je crois qu'on a une responsabilité pour dire oui, il y a des mécanismes qui ont marché chez vous, comme mon propre pays, en France, en Allemagne, en Belgique, mais je crois qu'on a le devoir de ne pas exporter en miroir les mécanismes qui ont marché dans ces pays-là. Pour la raison simple que simplement les contextes sont fondamentalement différents, notamment du point de vue de la structure du marché du travail. D'accord? Quand on a un contexte d'informalité à 90%, on ne peut pas importer un mécanisme qui a fonctionné dans un marché du travail très, très formalisé, comme c'était le cas en Europe à l'époque. Donc, pour nous, en tant qu'économistes de la santé, travailler avec ces partenaires bilatéraux pour éviter ce transfert en miroir de mécanismes qui ont été introduits en Europe il y a plus d'un siècle et les introduire aujourd'hui. Travailler aussi avec les gouvernements. Qu'est-ce que j'entends par là? À nouveau, quand j'étais en Côte d'Ivoire, mais encore une fois, c'est parce que c'est l'exemple le plus récent qui me vient en mémoire. Le ministre des Finances m'a dit « Oui, alors vous dites que l'assurance maladie, ça ne va pas vraiment marcher chez nous. Mais ça a marché chez vous. Pourquoi nous, on n'en bénéficierait pas? D'accord? Pourquoi nous, on n'aurait pas les mêmes gains dont vous avez bénéficié il y a un siècle ?» Et je crois que là, on a aussi ce travail à faire avec ces gouvernements pour expliquer que ce n'est pas une question de les priver de ces gains-là. Vous voyez encore la référence, je pense, à la colonisation. Ce n'est pas les priver de ces gains-là. D'accord? C'est essayer de trouver ensemble les mécanismes qui sont le plus adaptés à leur contexte. Et encore une fois, le fait de dire que, bah oui, ce qui a marché chez nous ne marchera pas forcément chez eux parce que les contextes sont différents. Ce n'est pas une question de priver des bénéfices, c'est une question de trouver ensemble les meilleures solutions. Et je voudrais finir sur le dernier point qui a commencé à être évoqué par Pierre. Si aujourd'hui, on essaye de trouver des alternatives à l'assurance maladie, je crois qu'il y a de l'espoir. Quand j'entends le Burkina Faso, quand j'entends Jimini de la Tanzanie, je vois qu'il y a des mécanismes qui ont été introduits à l'intérieur même des systèmes de budget gouvernementaux. Ce que nous a expliqué Pierre pour la gratuité, ce que nous a expliqué Jimini pour le DFF, ça ne passe pas par des mécanismes assurantiels. Ça passe par un ajustement de la gestion des finances publiques. Et ces ajustements sont possibles, sont faisables, ont été faits dans ces pays à faibles ressources pour mettre en place une fonction d'achat de services de soins de santé primaires principalement. Donc pour moi, c'est l'espoir aujourd'hui. J'ai l'impression qu'on n'en sait plus sur ces mécanismes-là aujourd'hui qu'il y a 10 ans, 15 ans. Quand il semblait que l'assurance maladie était le seul recours pour une fonction d'achat. Aujourd'hui, j'ai l'impression qu'on a la possibilité d'apprendre de ces exemples-là pour essayer d'être innovant, entre guillemets, en dehors de mécanismes assurantiels et que les systèmes gouvernementaux présentent une opportunité qui est sûrement aujourd'hui la meilleure alternative pour faire fonctionner cette fonction d'achat des services. Thanks a lot, and I'll pass the mic to Joe.
Thanks. Oh. Yes, I'm not going to go too many things because it's important actually that I think WHO ends the meeting, which Helen just did. And just to pick up on a couple of things. One thing that came up in the...
Don't think we
I'll do this. Okay, that doesn't work. You know, much of what... Nope, that's so... Okay, is that better? Yes, okay. Much of what we have been talking about in a way can be construed as kind of, you know, building the ship as you sail it, even though I don't know anything about ships. But it's this idea that you're reforming while you're building foundations. And this is really important. And I think Helen pointed to a few of these key foundations, which are critical in any case. One is information, right? To the idea of moving towards something more unified. Another one is really around the PFM systems that enable much more flexible use of budget funds. And as she was saying, and especially in this last point, you know, that in a way, anything other than out-of-pocket payment is some type of insurance function, right? So it's more really about what, you know, how do you build and strengthen? And part of our group was going on this. Key is really strengthening your purchasing function and doing that on behalf of the entire population. So I don't want to say too much, just a couple of random thoughts beyond that. One is we're at IHEA and thinking about, again, the economics of this. And one of the lessons I always take from the Argentinian case is to think about not just the total amount of money that's coming, but your marginal productivity effects, right? So that was one where a relatively small amount of money at the, injected triggered a big system-wide response. So keeping in mind that matters. Two last things. One is that idea that even if you have major problems of equity, for example, in access to services, financial hardship, the most important problem may not be the first step in the sequence of what you do, because there's a lot of this foundation building, this bamboo planting to do, right? So, taking on that challenge directly, in some cases is feasible. In other cases, it's still about building the data systems, building the purchasing, and making that happen. And this is really one of the part of the research agenda, as well as thinking about what in my country's case do we need to do to make things happen. And just lastly in all of this is to keep track of these points that Helen said, and focusing very much on starting with the problem you have and unpacking to get to the solutions that are relevant to you. So there's a lot you're going to be hearing during the week of a lot of good country examples. We've had a lot of really interesting cases from a number of countries, and hopefully you'll take those with you and see how you can see if there's some lessons that come out for your own case. But with that, I just wanted to thank again the organizers, the team, multi-agency, multi-partner, and multi-friend group of people to bring this together, and especially to all of you who've come and participated. And I hope this was useful for you as well. So thanks very much, and enjoy the conference.